All right, and welcome back to this lecture in orthopedic surgery for emergency physicians. We have gotten so far now that we're on to the last video here. And we have been through the general approach, and we're now making our way through the body with don't miss diagnoses, practical tips on examination, and so on. And we've reached the arm after being through with the leg. And the arm, we're going to go through the arm first, then we'll go through the back, and at the end we'll go through children fractures and maybe a bit of geriatrics as well. Okay. So hands, fingers, and wrists. It's no surprise they're sitting here on our model. For anatomy, I don't want to go too much in detail because there's a lot of anatomy here and a lot of details. So if you really want a deep dive for that, I suggest Andy Neal's lectures on emergency medicine Ireland. I've used a few of his pictures, and if you like them, you should check out his stuff. It's really high quality for emergency physicians. The pearls I'll go through in a little while, and just a bit of anatomy here first, and a bit of terminology. This is from Andy Neal as well. So it's important to know that when we talk about so far we talked about lateral and medial, but now in the hand area we'll usually talk about radial on the radial side here, and ulnar. There's a mnemonic knowing which side the radial is like something like radio car. Like if you grip your if you make your thumb and hand and forearm in a neutral position, then you can then your thumb becomes kind of a joystick, and then antenna, and then you like radio car. That's the radial part. It's a dumb mnemonic that we used, so use your own, but or whichever how you can remember it by. But radial is the thumb side, right? And ulnar is the other side. Then you can talk about volar or palmar if you come down here, and then dorsal. Okay, and then just a bit of anatomy here. Again, an Andy Neal slide here. So you have your hand here. You have your phalanges here. Your distal, your middle, and your proximal phalange. And you have your knuckles here, which is the joint here, the MCP joint, or the distal part of your metacarpus. And then you have down here you'll have your wrist bones, which will be in the next slide. The joints here, the dip, the distal interphalangeal joint, the pip, the proximal interphalangeal joint, and then the metacarpal phalangeal joint. Then you have your in the thumb your interphalangeal joint, and you have your MCP down here as well. So there's only a root joint and a EIP here, not a dip and pip. Okay. Here you have your all of the 8 wrist bones with 2 articulations. The one here, 3 articulations. Sorry, the one here, and then the one here. Okay. I'm not saying you should remember all of these. I certainly cannot. But there are certain that are important to pick out. The scaphoid, because you're a scaphoid fractures. The lunate, because we have a scaphoid lunate and pure lunate at this location that we are going to talk about. And then I guess you can break all of them, of course, but there are certain ones that are usually broken, and another one that is usually broken in the as usually part of this don't miss diagnosis is the hook of the hamate. That's usually a very specific baseball injury where the bat goes into your hand. So I think at least these 2 you should know, and then the last one probably more, but I guess you can go away with those. These pictures that I have from here is like, don't forget the bubbles. They have a great page on this as well. Okay. It's important to know and recognize that most of the hand is actually ligaments. And when we have an injury in the hand, we should probably think bones as the last part of, like, because ligaments is usually such a big part. And there are certain ligaments that are quite important for us to know, and we'll go through these. But just to mention two that are really important, there's the TFCC. I know I cannot remember what the name is, but the reason why the TFCC is so important is because, and we'll get back to it, is because when you um, in terms of function of your entire forearm and hand and wrist, the supination pronation is much more important when you ask patients after injuries than the flexion of your elbow, for instance, because you can do so much more if you can just supinate and pronate. And a lot of that movement is like the is this articulation between the ulnar and the radius, where it moves over, it moves over the each other here, and the problem with the TFCC here is if that breaks, then it hurts and it can create a lot of problems. Something called a DRUD, DRUD, a distal radial ulnar joint injury. And these are commonly missed, and we'll talk about those because they might be present isolated, but usually they're part of a fracture complex in this circle. This is another circle, just like the lower leg is a circle where it breaks two places. Then this is also a circle where it might break two places, the ulnar and the radius. Yeah. So this TFCC joint is important. And then you have your SL joint, your scapholunate ligament, not joint but ligament between the scaphoid and the lunate. And you'll see why that is important as well, because you might get something called scapholunate, or the spectrum. It's like there's a sequential kind of badness that can happen if you have an injury here, that with time will become worse and worse. They're quite hard to pick up as well, so it is nice to have a high index of suspicion of these as well. So the ligaments of the hand that are important to think about is the SL and the TFCC, I think. I'm sure there's a lot more, but these are the ones I think are really high yield for us. Then another anatomical pearl is that why are our forearms so important, and why do we not we will see that in local guidelines they usually don't accept almost any amount of shortening of if the ulnar or the radius breaks. So this is a stylistic painting of the ulnar and the radius and then the hand. And the reason why that you don't accept any kind of shortening of your forearm bones is that if just one of them is a bit shorter, then your entire hand will deviate, and you'll have a very disrupted function of your hand or your entire forearm. And so you'll see that in a lot of guidelines, except with children, you do not accept that much change in it's almost like a fracture here is almost always operative. The exception being the distal radius fractures, for instance. Okay, so let's go into a bit more nerdy about the hand surgeon's tips. We talked with a couple of hand surgeons, and they gave us some tips that I want to share with you. So tip number one, physiotherapy is everything in hand surgery. Okay, it's almost more important than the surgery. So because the hand gets really, really stiff really, really fast. And if you don't use it, you lose it. So it's really, really important that if there's an important injury in the hand, then you really need to train it, and you do not immobilize it unnecessarily. And the training has to commence quite fast. Okay, the hand surgeons, I think, don't necessarily watch themselves as only orthopedic surgeons, because they also have to know a lot about neurosurgery, like peripheral neurosurgery. They have to know about vascular surgery and plastic surgery as well. So they're like a hybrid kind of surgeon because of the complexity of the hand. Okay. You always have to do a very thorough neurovascular status. And because especially with knife injuries, the cuts are usually much deeper than you think, and there's so much structure that can be destroyed quite easily with just a small cut in the hand. So it's usually almost always deeper than you think. So be very thorough, and also the tendons. It's important to examine those like quite thoroughly. A tendon that is tight can almost be like destroyed by just having a small needle pointed at it, because when it's under high amount of tension, then it can break quite easily. But if it's not, if it's flaccid, then it doesn't break. So it depends on what kind of state the hand was in when the injury happened. But it's more to think of like the fingers have tone. When you examine the patient, the fingers usually have tone. If you look at your own hand, it's not lying flat on. If you just passively lie your hand on the table beside you, the hand has somewhat of a tone. The fingers are flexed, and if you have a tendon injury, the fingers will not be flexed in the same way if you have a flexor tendon injury. So it's important to notice these things with like these small nuances are quite big tips. Also, for certain injuries such as the flexor tenosynovitis that we'll talk about later, this passive flexion of the fingers are important to notice. Okay. One of the big tips was this: think of the hands as like, think of the homunculus. The homunculus, like the hands are such a huge part of the homunculus, and I love neurology, so this really speaks to me that that the hands are a huge part of the homunculus, and this is the motor homunculus. When you think about that, then you think about like how small injuries that are minor to the eye can have a huge impact for the patient, because we use our hands so much in everything we do, all the activities, almost all the time. So just small injuries that hurts are vastly that can be very detrimental to the patient. So it's important to be cautious and particular with the hands. We talked about like bones are maybe the last thing you should think about in the hands. We should also always think about all of the other stuff, all of the soft tissue injuries and so on. Some of the common misses in the hand are the usual, like we'll go through these systematically, but just some of the like often missed injuries in the hand are like soft tissue injuries, like UCL tears, tendon ruptures, nerve injuries, and dangerous infections, and so on. So think of the scared off mnemonic, the ones that are not shown on the CT or the X-ray. Yeah, it's important to know that the hand, because of its very ligamentous build up and fascias and so on, are very prone to infections. So we should really be liberal with antibiotics if there's a wound there, as opposed to other areas of the body where we might not need antibiotics if there's a wound and so on. And some of the infections spread quite fast, as we will see, so we have to be quite aggressive with that treatment. It's also important to say like CRP or other kinds of blood tests usually don't help, because the hand, like the area where it's infected, is so small, so it won't really relate. Like usually it will not translate to any amount of CRP, right? So it's clinical diagnosis these. Um, yeah, so he gave us this analogy that the hand is a precision instrument, like a watch, like a fine Swiss watch. And if there's an injury, it would be like imagine this finest like mechanics, like small, finely tuned mechanics. That would be the hand, like a clockwork. And then when there's an injury, it's like pouring inflammation glue into that clockwork. And the hand surgeon's job is like to try to pick up and get all of this glue out of this clockwork, and it's really hard. And so the expectations are a lot of times if you have severe injuries in the hand, it will not feel like the same hand again if you have severe injuries in the hand. It's important to tell the patients that straight up, that a lot of the injuries in the hands are not going to, like, it's not going to be perfect. It's going to be better, and it will be better with years or months of rehabilitation, but it will not always feel, oftentimes not feel completely like the same hand again. Okay. um, If it's hard to examine the patient, then use a finger blockade. We've talked about this in other areas as well, but here it's really easy to do a finger blockade if it's hard to examine. Um, with nerve injuries, if you're concerned, use the 2-point discrimination test, and you always do it vertically and not horizontally, as we talked about. Um, if um, if there are nerve injuries, usually they are not hyperacute. You can call a surgeon in like tomorrow morning, not during the nighttime. It's a different thing about vascular injury. That's right now, but nerve injuries can be dealt with in the morning. Um, and nerve injuries beyond around the pip joint, maybe a bit more proximal than that, maybe like in between the pip and the dip joint. Um, they cannot be salvaged because the branching of the nerves are so detailed at that point, so it's not fixable. As I say, it takes around 1.5 years before like a total healing has occurred for nerve injuries, so it takes a long time. And when they operate, a lot of the reason why they operate is sometimes this healing goes faster. I wasn't perfectly sure about that, but it seems like one of the reasons why they operate is because you can develop painful neuronomas if it heals in the wrong way. So that's what they sometimes want to prevent, so that you don't get a chronic pain in your hand. All right. The extensor side is much is much better, or much cheaper and much better at healing, and less complex than the volar side. If there are volar injuries, for instance in the fingers, and it's really something that you need to treat aggressively with rehabilitation. If you have a volar luxation or dislocation, then there's a lot of injury, like there's a lot of tissue that is injured usually, and it needs a more aggressive workup than the dorsal stuff. Also, extensors are usually not as important as flexors, or they heal much better and so on. So there are different things. So the dorsal side is as a rule of thumb better to injure than the volar side. Okay. We talked about knife injuries. You really need to do a really careful exam because the wound size does not portray the amount of injury that can be caused, especially if the hand was like under tension during the time, or the tendons were under tension, then they can easily break. Okay. Then there's this great analogy, I think, about the hand and why you do not um, why it's important to think of the hand as an entirety. So if you and the example would be if you have a finger amputation. Usually, if you have a finger amputation, they do not replace it. They do not sew it back on, because, as we talked about, the finger will never be the same again. It will be stiff, and the thing is, if you have one finger that is stiff and the rest are good, then it will be the rotten apple. And with one rotten apple, with this homunculus, with such an important part of the body that moves all the time, then it will destroy the rest of the like it will incapacitate the rest of the hand. So one rotten finger will spoil the rest, as I understood it. So that's why you don't want to reattach a finger once it's off. And we'll go back to amputations in a little while, because it's important what we say and what we talk about for expectations for patients. Um, yeah, it's a different thing with children. They can, but think about the neural plasticity of having one finger that is bad. If you have one lumpy finger and the rest of the hand is good, then you will quickly compensate by not using that hand, and that's the problem, right? So then you'll unlearn, as you can unlearn, as we talk about the biopsychosocial model in the first part of this lecture. You can unlearn or learn bad habits and so on. Then you can unlearn what you actually know about your hand. You'll just use your other hand all the time, because the other one is too difficult to use, right? And then your other fingers and then will just not be useful anymore. So yeah, so that's the. I'm sure there's a lot of research going behind that, but that was what our hand surgeons told us, and that's why the guidelines are as they are. Okay, the scared off for these is, so for infections, they are there are the Baxter fractures. Remember to remove the teeth that might be sitting there. I think it's around 10% of the Baxter fractures with a hole under skin. Open fractures will get septic arthritis. So it's really important to treat these with antibiotics. The flexor tenosynovitis, which we'll go back to, is important to pick up because they can turn into also phlegmony and destroy the fingers. Then you have your pulp abscesses, and you have your paronychia. There's lots of other infections, but these are, and you of course always have septic arthritis, but these are some of the important ones. Compartment syndromes, of course, they can happen, especially in the forearm, but not that commonly as I know in the hand. Non-accidental injuries, we'll go back to those, but not that common here. You have your referred pains, not that common either. Your dislocations, I told about the volar dislocations, are really important to pick up. They're rare, but they need to be treated more aggressively than your dorsal dislocations. Your soft tissue operational injuries are your UCL tear or rupture. You have some tendon injuries that, especially the volar side, are the flexor tendons are usually something that needs to be cared for by a hand surgeon, not necessarily operated on, but cared for by a hand surgeon. And then you have these high pressure injuries that are really important to pick up as well. There are certain others that are important, but these I think are the most important, and what I could find was repeatedly mentioned. Then you have your wrist, and there's a lot of fractures, but some of the most important ones are the druge, the distal radial ulnar joint disruption with the TFCC ligament disruption. You have your scaphoid fractures. You have your scapholunodum dislocation or dissociation. It's a spectrum of problems here. And then you have your hook of your hamate. And then you have angulated fractures of your the metacarps. Metacarps. These are usually needs to be operated on as well. Okay. So then you have your the tips or pearls here, and it's so some of these are I think we've been through a lot of these, but one of this, if you do sutures over something like something that has to move, then you have to use, first of all, don't use glue, don't use Steri-strips, use the one with the most tension, which would be sutures, and they usually have to stay in for a longer time, maybe 12 days instead of I don't know, maybe 7 to 10 days. Okay. Um, for bleeding, we talked about never clamp the arteries. You should use what I told you earlier on. Always consider prophylactic antibiotics, especially with bites in the hand. Um, immobilization of joints here again, it's really like they should be using their fingers almost right away. There are certain exceptions to this rule of maximally 1 to 2 weeks. That would be swan neck like mallet fingers and swan neck malformations, but these are like really specific things. Usually, you should try to move the fingers as fast as possible. It's important to know that when you foosh, like fall on outstretched hands, then usually, again, this is an age thing. Um, older people, people from 15 years of age around until 50 years of age, they will be the ones who have breaks in their most commonly have breaks in their wrist bones because all other elements are so strong. But children and elderly will usually get fractures either in the elbow or the forearm, such as like for elderly, or for above 50, middle-aged and above, um, like distal radius fractures. Yeah. Yeah, I think that we'll go through the rest later on. So, examination. You do your inspection, of course. Inspection is always 360 degrees around to see if there's any open injuries. You do your neurovascular status. You do your palpation. And I'll just jump to the movement or function. And here you do your function test, and you check for passive tone in the fingers. And then you check the superficial and the profundus flexors. And I'll show you in a picture soon how to do that. And you check for the extensors as well. It's important to do these specific tests as well. You'll check for stability in all the joints, especially the UCL joint is really important. There's a specific 6-point test that you have to do for the scaphoid. 3 points. It's a 6-point test, but it's only 3 tests that you have to do for the scaphoid. You have to always check for rotational rotational injuries in the metacarps by doing, I call it the tiger finger thing, but it's I'll show you. Okay. So this was how you test for the flexor tendon injuries. You for the for the superficial one, you will have to immobilize all of these fingers, and then you're only testing that part. And for the profound one, the one going all the way out to the distal phalanges, you just have to push here, and then it'll move. So you have to do this for all the fingers, and some people's fingers cannot. I think it's I think it's the ring finger. Some people's finger cannot do all the way that because they're lagging some kind of muscle. But just check with the opposite side. And if it's only on one side, then I think it's the ring finger, but you have to check what kind of finger that usually is a problem with. Okay. Here's the picture of a flexor tendon injury where the tone of the flexors are done and then are off, and instead you have extensors pulling this into a more extended passive position. Okay, and here's the rotation thing. The rotation thing can be you can look at the fingertips as well, where they like do a tiger claw kind of movement towards you. But you can also do this where they kind of where all of the fingers have to point to to the scaphoid. And if there's any rotation, you have to check with the other side, but usually it's quite obvious that there's a rotation. Okay, there is a specific, because of the this TFCC is really often overlooked. I will just go into detail how to actually examine this patient. Usually, if you have it's usually a Fuchs injury, and if the patient has Fuchs and they are quite tender on their distal radius, um, and maybe have broken distal radius, then it's really hard to actually examine this, or if they have a lot of swelling. So either it's either they haven't broken their bones so that it's not that hard to examine, or they come in after a week or so because it's still hurting a lot in that area despite them having just fallen and they thought it wasn't broken. Some specifics are usually that it hurts more on the ulnar side, around the styloideus ulnar for the TFCC. And there's a specific, and the for the SL ligament, it's usually they have. I'll show the soft spot on the hand where you have to check. But if it's swollen there, and if it really hurts specifically right there, and then like it hurts more than you would suspect, then that's where you suspect this one. But these are hard, especially the SL ligament one is really hard to pick up because it also needs a specific kind of X-ray. To pick up, and you will, as our hand surgeon said, you will not catch the SL ligament all the time. The other thing with the SL ligament is that it's a spectrum, right? So it might not be obvious at all at first. You might only see the X-ray. Might, even if you take the right X-ray, it might be normal, and that's a problem because with time, if there is an injury, then the movements of the hands will pull the two the scaphoid and the lunate bone apart. So the like if you take the X-ray 4 weeks later or 2 weeks later, then it will show the what you call the teratomas sign. So it's like a Trojan horse kind of diagnosis. So you might have done everything right, but you'll still have you might miss it at the first X-ray, and you have to do sequential X-rays to pick it up. And and you only have I think it's like 6 weeks to actually do operations on it, because beyond that, the cartilage has worn down and it's not resolvable. So I guess our hand surgeons told us that it is really hard to pick up all of these, and if you have to X-ray all of them and follow up all of them and immobilize all of them only on the suspicion, then it's probably not sustainable. But follow local guidelines again. I'll just show you how to test for these. Okay, so you have your styloid. And if you right above the styloid, you can feel like a soft spot, like you can feel a small area, and if it hurts right at that spot, like in that like small soft spot here, that's the foveal sign. If it hurts right there, it's really it's specific for a TFCC injury. Also, if it hurts on the ulnar side in general, and it's also specific for TFCC injury, and you should consider treating it like that. And maybe do an X-ray to see if there's any obvious TFCC problems. You can also do what you call a piano key test, where you make the patient with palms down on a hard surface with both hands. Try to push down as much as you can, and if the test is positive, if the styloid goes up, and you can like press it down as a piano key. For the SL ligament, it's there's a small soft spot on your hand, right around, like if you follow down the around your fourth finger, and go down, then you'll around here find a soft spot where it really where that's right above the pirineum, or this SL ligament. And if it's swollen right there, and if it really hurts there, then that's enough to consider this and then maybe arrange for follow-up. When you test for the TFCC as well, you'll do this as well. You'll grab the patient like this by the radial side, and then you'll pinch the ulna and then try to move it up, move it up and down like this in a rocking movement. And if that hurts, or if there's a significant give, then that's also like highly suspicious for a TFCC injury. Okay. And we talk about the TFCC here, yeah. Okay, moving on to the don't miss diagnoses. All right, let's talk about finger infections. And there's a lot of them, and I'll just go through them one by one. So you have your, what you in English call a filan, or what you in Swedish call a pulp abscess. These are really important to pick up because it's like a small, like compartment syndrome, local compartment syndrome of the pulp of the finger. And the reason, like the way it's a clinical diagnosis, and the way they're treated is by cutting a knife through all of these small compartments, and that can be done by cutting a knife like from radial to ulnar side, and then all the way through, or not all the way through and just slipping it all the way here. But we were told that we should that the hand surgeons usually tell their residents to open it like a calzone pizza, so like in a U shape, all the way up here and then all the way around and then back again. And then you don't suture anything. You just bandage it up and arrange for follow-up with or without antibiotics. Depends on local guidelines. Some say no, but it's important to like empty all of these small chambers here, and it's something that at least in Sweden is done in the emergency department. So yeah, do a finger blockade, and that's how you do that. And then make sure to give them some kind of painkillers afterwards, because when the finger blockade is off, then it hurts. Okay. Here's the calzone pizza. This is the reason why you should open it like that, all the way around in the U shape. Okay. This is a paronychia. Paronychia is a small infection going in here on what you call the paronychia as well. There are different ways of treating this. I think that one of the good ways of treating this is shown on Don't Forget the Bubbles YouTube channel, where you put it into hot water for 10 minutes or so. That will like really soften up this area, and then you can, without cutting it, get a needle in there, and then just like tilting, and then you will often release the pressure and release the pus. And then you have to make the patient keep doing that at home for a couple of nights to like release any excess pus. And then you have to squeeze so that everything goes out. That's usually a bit painful. But usually you don't have to cut anything. You usually don't have to do a finger blockade if you do it like that. I know certain places will treat these as well with antibiotics. So again, depends on local guidelines. Then you have this really a don't miss diagnosis. All of these are clinical as well, by the way. As I said, CRP doesn't really help. So this is the infamous flexor tenosynovitis. There's these 4 Canaveral signs that are usually associated with this, and they don't. All of these rare diseases that they don't usually have all 4 signs at once. The history is usually like this. They usually have some kind of pinprick on their finger, on the pulp of the finger, or somewhere around the finger. And then they come in maybe 6 to 48 hours after that with a finger that is fusiformly swollen. It's really important. It's not locally swollen. It's swollen throughout the finger, as you see here. It's all around the finger. It's also hold in a passive flexion. Yeah. And if you flip on like if you percuss or if you passively extend the finger, it will hurt a lot. Okay, and this is often associated with what you call V phlegmoni in Swedish. I'm not sure the international word for this, but um, it starts hurting in this finger, but then suddenly it hurts in that finger because the infection has spread along the flexor tendon sheets. The ligaments and structures in the hand, and this is an emergency. This is something that needs to be talk with your hand surgeon or your plastic surgeon, depending on local politics. But like talk with someone who knows something about this right away, and they often need to be admitted for antibiotics and oftentimes operative management, depending on which local guidelines are and how they practice and so on, and how far gone the infection is. Okay. This is not an infection, but this is what you call a high pressure injury, which might lead to infections as well. But I brought it along here because it's in the fingers, and it can present somewhat like that, looking like an infection. But usually the history is quite clear. Like they had some kind of high pressure stuff that was pushed into the finger, and it doesn't look like much, right? But the amount of injury to the finger is vast, and it's an emergency. Also needs to go to the hand surgery department right away. Okay, again, biters like what you call fight bites or boxer's fractures, especially fight bites, right? I put along here as well because 10% of fight bites, they will develop septic arthritis. It's really important to pick out any piece of teeth in their bone in their injuries, because otherwise you will just have an abscess right away. There's a you will do the rotation test, see if all of the fingers are pointing towards the scaphoid bone, and if they don't, then maybe you need to do an operation on them. If there is a luxation here, or if it's you can fix it by pulling on that finger, like using the finger as leverage, and then fixating in that position with what you call I think it's called a cobra splint, where it's like you have a splint going that up there and then down there, like with your hand in like a flexion. But we were told on the course that you don't really need to do that anymore, because apparently the conservative management of it will go back. So check your local guidelines, just saying that it's quite an easy thing to reduce using your finger as leverage, but you don't necessarily need to do that. So what you need to do especially is check for rotation, and you always check for teeth and use antibiotics, and then arrange for early follow-up. Okay. Amputations. So in general about amputations, whether or not they're salvageable depends on the muscle involved, because it's the muscle that are the time critical thing. It gets ischemic first. The nerves, we talk about the nerves beyond the pip joint are non-operative, and you don't repair anything beyond the first finger. Sorry, if you don't repair if it's only one finger, because we talked about it will be if it will not be the same finger when it's reattached. It will spoil, and it will spoil the rest of the hand if it's reattached, because of the homunculus and neuroplasticity and so on. The exceptions being if it's a thumb, and if it's and also if it's any finger of a child, because there's a higher growth potential or development potential there. If a finger or any other limb is ever amputated, you should rinse it, put it in some lightly like the damp gauze, and put that in a bag, and then put that bag into another bag with cold with ice or cold water. Um, there are other ways of doing this, but this is usually the most effective way. Um, if there's a tip of a finger amputation, like if you have a stump, like then usually they don't, like they don't reattach it. But what they do is that they will consider doing some kind of like grinding down the bone. But they'll only do it if it means that you come back to work faster, because otherwise the body will take care of that problem, the bone, and grow nicely over it in around 2 months, they say. Yeah, so a bit nihilistic about these amputations, but just so that we can explain for patients the expectation and their, like, what they can expect when you're sending them, and or why we're not sending them to any kind of amputation management. Okay. Um, Burns in the hands are really important. They should probably be, you should have a low yield of checking in with a hand surgeon about these, because again, the hand is so important. Scarring is really problematic. If there's just if there will be scarring, is really problematic. You can, for to check whether, like, one of the most important things is to check whether there's bleeding and nerve sensation. These two, if there's none of these two, then it's a grade 3 burn, and that's important to, like, check, of course, the extent of. There's always a debate on whether or not to remove blisters, again, with the hand, because you don't want to immobilize the hand for any amount of time almost. Then you actually, our hand surgeons said that we should remove blisters. Because then the function of the hand will be better, so that you don't have a blister in the volar aspect of your hand. But it depends, of course, and on the rest of the body, there's really no evidence of removing blisters. Check out first 10 EM's blocks on this. All right, tendon injuries. Just quickly, flexor tendons always operative over an ortho decision. Extensor tendons may be managed conservatively, but you have to check with local guidelines, and it may just need the horizontal mattress suturing, absorbable. But usually, I mean, our hand surgeons recommend that. I mean, unless you're working somewhere where there are no way of professional management, emergency physicians probably not do this. I've seen it done a couple of times in the emergency department, and I mean, I've never done it myself, but it really depends on local guidelines whether or not you should do these, and whether or not you feel comfortable doing these. All right, UCL rupture, or skier's thumb, or gamekeeper's thumb. Yeah, these are injuries where the reason why it's called skier's thumb is because when you hold your ski staff, and you get an injury like that, and then you will break the UCL, the ulnar collateral ligament, so ulnar side here, and the collateral ligament is one going from here to here. Okay, so what you'll see when you do this is that you will see an open book kind of open book kind of way, and when you fixate the rest of the hand and you press that way, you can feel lassity, and it opens much more than the other side. It hurts, so you might need to do a blockade before you do it. You also do an X-ray, because there might be an avulsion fracture as well, and in general, you splint the thumb and then you follow up in 7 days, and you assess whether or not it's a full rupture or a partial rupture, and whether or not they need operation or not. Yeah, also if you do a pinch grip, it will be painful for them as well, but usually it's enough to just do that. All right, going on to the big one, the scaphoid fracture. So right off the bat, this is always something that we have, like, the test for this is really bad, like the X-ray. The MRI is good, around 100% sensitivity as well there, but we don't have access for MRIs for these usually, beyond maybe 7 or 14 days. So there's always a question of when we have to actually immobilize the joint, and I guess local guidelines differ here as well. But I'll give you my suggestion and how I was taught this. The sign we have down here is one of the more diagnostic signs, called a clamp sign. If you ask the patient where does it hurt, and they show like this, like a clamp on the scaphoid, then that's very specific, but it's not that sensitive. In general, these are most commonly seen in the young population, around 20 or 30 years old, because younger people or older people will have stronger or weaker ligaments, and therefore they will break bones higher up in the body, such as distal, or more proximal in the body, such as elbow fractures or distal radial fractures. So scaphoid fractures is what we see here when they foosh. Yeah. Around 30% of these are falsely negative on X-ray, and it's really about millimeters whether it's a true occult fracture if it's cut in the wrong way or in an unlucky way. So that's why it's like theoretically it's so hard to pick up all. It's impossible to pick up all of these. That's just the problem. That's why we do treat them as we do. And Arun Sayal usually talks about this, that of all the foosh injuries, distal radius injuries are much more common than wrist injuries, because distal radius injuries are around 80%, and wrist injuries or wrist bone injuries are around 20%. But of the wrist bone injuries, 70% of these are scaphoid fractures. So this is the most common, and it's an occult fracture. So it's one of these fractures that we really have to have a low threshold for. And I think we actually do have that as well, but it's always an argument whether or not to do this. So the mechanism is a foosh injury. How you diagnose it is there's a point system here. And if you get 6 points, then you have a 70 to 90% likelihood of having a scaphoid. If you have only 1, then you have a 30 to 50% likelihood. And 3 points, if you give 3 points or more, then you'll have to do a cast and do a scaphoid view X-ray. All right, so the first, you get 3 points if you're tender in your snuff box. All right. Some people are tender in the snuff box, but you have to check for the other side for baseline. It's important that the patient's hand is deviated towards the ulnar side when you're pushing on the scaphoid, so that the scaphoid bone is all the way to the surface of the skin, or as much as it can, and you'll do that by doing ulnar deviation. Around 25% are a bit sore in their in the tippy share or snuff box usually. So then also you will check for in the volar aspects of the scaphoid. Press there on the volar side, and that will give you 2 points if you're tender there. And that you will have to do in radial deviation, and to get a bit better volar push on the scaphoid. And then the third one is the axial loading, and this is quite tricky. You only get 1 point for that. And if you do axial loading compression here, then a lot of, like, I think it's about 50 or something like that, a lot of people will have arthritis, arthrosis, because of old age and usage. So you're not allowed to use this one. It's false positive in elderly people, and should not be used in above a certain age. And always check with the other side, of course. But with these things, there might be specifically unilateral differences. And then you have the clamp sign, as we showed here. And it has a likelihood ratio of 8.6, so it's a good sign. There are other signs as well. If they have pain on supination, if they have a reduced range of motion of the thumb, or if they have pain with in the end of certain movements such as flexion or radial deviation, or if they have pain during a pincer movement. Then the tactics of how you will work, like usually you'll do a cast on these if you have a high suspicion, and the cast used to be a quite big one, but according to the course directors, there has been a recent, it might have been an RCT, or at least a recent study saying that you can get away with a minor, like a radial cast for these. And that's important because they don't have to be so immobilized. One of my friends had one of these casts, and she totally thought it was the worst thing ever, and it was just for a few days. So like immobilization of the joints is really, like, we think it's nothing, but it's really a big thing for a lot of patients. So we need to consider when we do these things. So there are different modalities that you can use. As I said, the MRI is around 100% sensitive. Some like a single X-ray is only 30%. It has a 30% false negative. So you have to do some kind of follow-up if you have a high precise probability and it's a negative X-ray. And the X-ray follow-up can be a reasonable thing to do when you do sequential, but it'll have the same problem that the rays of the X-ray are not hitting in the right way, so it might be truly occult still then. You can do a CT scan also, but it's not 100% sensitive either. So it's the MRI that actually is the best test. Yeah. Here we see the snuff box right here, and Emilia here has done it in a perfect ulnar deviation, so that you get the scaphoid bone right there. Okay. Then we'll go on to some other wrist bone fractures. So there is the scapholunate dissociation, where this is the SL ligament problem, where you have a injury right there, where if it hurts in that soft spot and it was swollen in that area, then you will do an X-ray, and you will do a specific X-ray called the clenched fist X-ray, where you might or might not see what you call a teratoma sign, because it really depends on if it's a minor injury right now. Then in a couple of weeks, then it will be much more obvious, because the bones will break apart, as we were told at least. So it might be occult at first, even with the fist X-ray, the clenched fist X-ray. So that's a problem, and that's why it's hard to pick up this teratoma sign, or it's also I've heard it also called David Letterman sign, is because of the the hole between Terry Thomas's teeth, and it looks like a hole between teeth. This gap here. You might, at a later stage or at a more severe dislocation, get what you call perlunate and lunate dislocation. There's something called the 4C rule when you look at the X-ray and lateral. There should be 4 C's that align with each other. The C here of the radius, and then there's the C here of the lunate, and then the C here of the capitum. So 1 C, 2 C's, 3 C's, and 4 C's. All of these should line up. If they don't, then it's then it's a problem. All right. So just to be clear, the first C was the radius. It should fit into the lunatum. That's the second C. On the proximal part of the lunatum, and the distal part of the lunatum is the third C, and then the fourth C, the capitum. This one here. So these 4 C's should line right up. Yeah. And then you have to hook up the hematum. You need a special kind of X-ray for that, called the carpal X-ray or the hemate X-ray. I might have called all these wrist bones, but they're also called carpal bones, I think. Sorry for my terminology. Okay, then we'll go to some of the common stuff. You have tendonitis or tennis elbows and so on, inflammation of the joints, and the hallmark of these, as shown with this Finkelstein test, is that when you use the when you extend the muscle, it'll hurt. So that's usually one of the hallmarks of tendonitis. There are other things as well, just to be clear about you have muscle inflammation. This is common, and usually you'll have them on either the muscles up around the elbow, on the ulnar side, or the radial side. Then you have mallet fingers or the other kinds of deformities, swan neck deformities, and mallet fingers. Usually it's the classical presentation in the script is elderly people having low energy trauma buttoning their shirt. For these, usually you don't need X-ray. You can't do an X-ray to see if there's an avulsion anyway. But it's more so like if you have a ball being hit directly on your finger, then you might sometimes develop these mallet fingers. And you'll do the X-ray to check if there's an avulsion. You'll inform the patient that the finger will, with high certainty, not be quite the same. There might be cosmetic problems, and the finger will beat down like that. And the treatment is usually strict. And this was the exception to the rule of how to immobilize fingers. It's strict immobilization for 6 to 8 weeks, even during sleep. Because if you remove, then you have to start all over. Check out OrthoBullets for details on this, because it's something that we do see sometimes. All right, that was a short hour about the wrist. We'll move on to the elbow now. And I'm sure, hand surgery is a huge area, and there's lots and lots of more to talk about. But I think for emergency physician use, this is more than enough. I hope I covered most of the important stuff. And please write below if there was something I missed. Then we move on to the elbow region. The elbow is situated here. We'll go through the anatomy in a short while. And for this, these first 2 pearls are that there are certain radiological. It's a hard area for radiology. It's easy to miss some of the most important fractures there, especially in children, but also in adults. And what you really need to look for, one of the small piece of bone that is really important, is the coronoid. It's it's part of the ulna keeping it in the joint, and if it's off, the joint becomes oftentimes unstable, and like the one of the few very like good classification systems that relates to to a treatment evolves around for elbow fractures evolves around this, whether or not the coronoid is off or not. So it's really important to look really detail about whether there's a coronoid fracture or not. And sometimes it's occult, so that's why you have to look at these indirect signs sometimes to check. Also this is like, we're still talking about the forearm here, forearm and elbow, and the forearm, as we said, is a Vanillikrans. It's like one of these circles where it doesn't only break one place, it either luxates or breaks as well in two places. And then it's important to say that supination pronation is much more important for patients than flexion and extension in the elbow. We talked about that before as well. Okay, here is Emilia again with her elbow. When we check for things here, then we can here see it's around here, the radial head, and here you have the lateral condyle. You have the olecranon here, and you can also see the olecranon down here. And then you have, again, the lateral condyle and the medial condyle. If we have an x-ray over this, you will see the humerus going down here. You have your radius with the radial head. You have your ulna, and you have your olecranon. And here's this piece of bone here, attaching right here is the coronoid on the ulna. A really, really important piece of bone. If we and here again we have the radial side here with the lateral condyle here, and the medial condyle here, and the ulna. Looking a bit more in detail, I don't think you need to know all of these things. The things that I just mentioned, like the coronoid, is really, really important. The radial head is important, and then the olecranon, and then maybe the condyles here are important to know about. Then you have this fat pad, and I think in the next picture will become obvious. There usually is an anterior fat pad is usually physiological. A posterior fat pad is always pathological, but a big anterior fat pad, what you call the sale sign, is usually is pathological as well. Okay, but the elbow is one of these joints where is really especially in children, where you need to do maybe do an x-ray of the other side. There are certain lines that are important here. The radial capitellum line, so the radial should line up with this area here. It should be a straight line, and the same with a line from here to and down here also to the capitellum. Then there's some of our orthopedic surgeons talk about this back area, and I haven't been able to confirm this in any way, so it might just be empirical from him. But we ask, how do we actually know whether the coronoid is off or not if it's occult? And one of the things he said that was important, I think, was make sure that the patient's x-ray is taken in neutral position. If it's supinated, then it's harder to see, and if it's pronated, then it's harder to see, according to him at least. So, and again, this is anecdotal because I haven't been able to find anything on it. And you can see if it's supinated or pronated on, as I understood it, the area behind here, whether it was flat or bulky. I can't remember which one was which, but maybe you guys have heard about the same thing, and then please comment about it, because I haven't been able to find anything about it. Okay. Another thing that I would just hint at is that look at the symmetry here. It's symmetrical, and the reason why this is important is that if there's a luxation and there's still no symmetry after you reduce it, then you have to think of a coronoid process injury as well. Other features that where you might have a high probability of a coronoid process fracture would be if there's a huge swelling with a luxation or with a fracture. If there's a big swelling, then or as asymmetry after you have reduced it, or if you actually see a fat pad, but no fracture other places, then you will consider doing a CT scan to actually assess this area decently. Okay. Yeah. All right, here again, it must be neutral. However you want to assess that. I was told this was the way to assess it, but I'm not quite sure. Here you see the fat pad, and here you see an excess fat pad, what you call the sale sign. Then you have the coronoid, and the coronoid, as I told you, was king here. It's really important to. I think I've hammered at home. The coronoid is really important to look for. And you have a high probability of a coronoid fracture if there's a big swelling in the elbow joint, and if there's asymmetry after a reduction, if there's been a dislocation. Also, you have to think about if you have the head of the radius fracture, then you should always that's also a red flag for look for other stuff because of this ring structure in the forearm. There must be a break somewhere else. Look for the coronoid because then if there's a break in the coronoid, then it might be part of the unlucky triad of the elbow where it's really an unstable joint. If there's a fracture, you might also think of there might be a luxation fracture somewhere, and we'll go into the luxation fractures of the forearm as well. All right, so the scared off, well, infection-wise, cystic arthritis and bursitis is something that sometimes happen. Compartment is common. It's the second most common place in the body to get. Compartment is the forearm, even though the lower leg is much more common. It's the runner-up. Dislocations. You can get the posterior luxation or dislocation by fushing. Not like operative soft tissue injuries. You do see I didn't put it here, but the distal biceps tendon injury. I don't know why I didn't put it here. It should be here. So the distal biceps tendon injury, because the distal bicep only has one tendon attachment, but the proximal heads have two. And with proximal head injuries, it's only a cosmetic problem. The function of the arm is not destroyed. What I've been told, and what usually the guidelines say. I'm not sure whether if you're like a really big guy and you're or girl and you are lifting, you might feel that there's a problem, and you might have to do an operation for that. But I'm not. But the distal ones are at least almost always operative, I think, or something that you need to be aggressively managed with. And you have your fractures. And these are occult because you often don't think about them, or if you have like a fracture one place, you don't think about the other fractures other places. You forget the other fracture, so to speak. The first fracture is the most commonly missed fracture is the second fracture, right? So we'll go into the Montegia and the Galizia fractures. We'll also go into some other more rare ones, and we talked about the coronoid. If you have the combination of a coronoid fracture, the capo radius fracture, and a dislocation, you have what you call a terrible triad, and it's a really unstable joint, which is operative managed, I think. And then you have your olecranon fractures, which almost always have extensor defects. But I think they are becoming much more conservatively managed now than they used to. All right. So other tips here. The pearls are if you, as a rule of thumb, if you can fully extend your elbow without any pain, then there's probably no reason for X-rays. I would though usually say that you should also probably be able to supinate and pronate. But yeah, then I think it's from EM cases. Fractures can be occult, especially with children's X-rays, as we talked about. So the radiocapitellar line are important. The fat pads are important, and the sail sign and the coronoid is important, right? We also, when we come to pediatric fractures, we'll also talk about these small bone growth areas that we will talk about the mnemonic crito and whether whether the the child elbow, whether what you see is a growth area or it's a avulsion. So that's something to look forward to a little bit later. Yeah, I think that the rest of these things we'll talk about later. So we'll just go through. All right, so how to examine? You'll do an inspection, of course. Nothing much to say there. If there's an obvious dislocation or if it's really swollen, then you have to think about fractures and you have to think about coronary fractures, right? If you palpate, it's important to palpate the head of the radius. And if it hurts there, then you have to examine the other, like a joint above and joint below, especially a joint below, like distally, really, really closely, because there might be a fracture somewhere else or a dislocation somewhere else, like a Galecia or Montekia, right? You check for the hook sign of the biceps. It's not always you have this muscle belly in the middle of your arm, so you have to check for the hook sign. I'll show you how. And you'll check for extensor defects. But as the lecturers pointed out about the extensor defects of the elbow, it's kind of hard to know when they start and when they stop, how to measure these. But do your best just to try to communicate how from where to where. Then you'll check for movement, and it's important. There's one pearl here to try to eliminate the gravity from the equation. So make the patient point to, like when you examine the patient, make the patient point towards you with their elbow, and then put their arm down on a table or something like that, so that the arm is lying with the elbow pointing towards you, so that the gravity is eliminated, and then they can extend their arm with eliminated gravity. Also, when you're testing for supination pronation, then keep the patient's arms to their side, so that they're fully adducted in their shoulder, so that they don't move any other areas to compensate for any pronation supination problems, and make them put their thumbs up, so then you can really gauge how much defect is going on there, because you use the thumbs as a measure of degrees. So when you have your elbows to the side and you have your thumb directly up, then you can supinate 90 degrees and you can pronate 90 degrees around that. And if it's below that, then it's a defect. Yeah. All right. Here's Emilia's arm again here, and here's the biceps tendon, the distal biceps tendon. So what you want to do is, with the hook sign, is to go in here, so that you can like feel this hook. And if you can't feel that, then it's off. All right, going on to the don't miss diagnoses. So we talked about these X-ray findings. I think we've been through all of them. I'll just repeat the radiocapitellar. This is a child's elbow, by the way, because there's ossifications here. So this is a radiocapitellar line. The capitoidum and the radial should align. Then you have this anterior humeral line, again, should align with the capitatum. Then you have your anterior sail sign, which it should not be this much. It should be a little. An anterior fat pad is normal, but it shouldn't be a big sail. And then you have your posterior sail sign, which is always pathological. Okay. And we again have your coronoid process, which is important, and it's important to check out whether this line is symmetrical after reduction. Okay. All right. So your posterior luxation. Usually they know it's really painful, and I think we went through this earlier on, so I don't want to go into too much about this. The only important thing is again to tranquilize them easily, to give them IV sedation usually, and to reduce it in supination. And always get an X-ray before and after. Always check for neurovascular status before and after, and always check for stability before and after. The thing is then that if the post-reduction film is really asymmetrical still, or there's a big swelling, then you have to think about a coronoid fracture, and we'll go through these now. Sorry, in a little while. All right, so according to EM cases, it's really important to know whether or not there's an extensor defect for these olecranon fractures. But according to our lecturers, there was always an extensor defect, so might as well not care about that. But it's important to notice at least, and to put down in the chart. Then you have to check for, is there an ulnar injury, and has there been a soft luxation or a luxation. All right. Then we go down to some of the forearm fractures, right? And luxation fractures or the complex fractures. All fractures here are usually something that needs to be operated on because of the hand, right? They cannot be shortened at least, and there are some exceptions with children and the distal radius, right? As we know, it's also break one place, it'll break several places usually. So the luxation fractures, you have your, I mentioned Drury, the distal radius ulnar joint. We already been through that it can be part of a lot of fractures when you foosh. And I won't go through any more of it. It's just check your local guidelines for how to treat these if you find them, because there are they're important to pick up because of the importance of the supination pronation function of the arm, and quite a minor injury can lead to quite big inabilities there. All right. And as I told you as well, the Drury injury is usually part of, it can be part of a luxation fracture complex as well. You can have a Drury and a radial fracture, and then that would be a Galetzia. Or you can have a Drury and a bigger syndesmosis injury and a caput radium fracture, and then that would be an XX Lopresti fracture. So these are like the Galetzia, the Montegia, and the XX Lopresti fracture. These are the more complex luxation fractures in the forearm that are always operative. And at least the Galetzia and the Montegia are mainly children, but they can be adults as well. Okay. So we have to consider this kind of spectrum, the Drury spectrum fractures and luxations when there's a distal radius fracture. Meaning not your collis fracture, but more the fracture somewhere on the distal part of the radius, right? So we already talked about the fovea and the piano key sign. The reason why we do X-rays of this is that there might be these criteria for a drush. They don't need to be. They're not sensitive, but they might be there. And it's widening of this space here. It should be 2 millimeters, and if it's beyond 2 millimeters, then that was the magical 2 millimeters there again. If it's beyond 2 millimeters, then it's highly likely that it is a drush injury. And then on the lateral side, you might see a dislocation of or subluxation of the ulna. Yeah. All right. Here we have the classical Monteggia and Galeazzi fractures. The Monteggia fracture is the proximal ulna, one third of the ulna, with a head of the radius luxation. All right, and the Galeazzi was the distal radius fracture with an drush injury. Okay. These are always something that we need to think of, and sometimes we need to take considering the central X-ray thing, where we need to keep the thing in mind, the thing in interest in the middle of the picture. We might have to do an X-ray of both the wrist to assess the distal radius or this area, and one of the elbow, but also one of the entirety of the bone, the forearm. Depends. Especially with the Essex-Lepresky fractures, we might need to do that. Okay. And just a few more pictures of. Here's the Galeazzi with a distal one third again, and with drush injury as well. And here's the Monteggia with a subluxation or luxation of the caput radii and a proximal ulnar fracture. Okay. Then you have this terrible triad. The terrible triad was a luxation of, a fracture of the caput radii, and a luxation or subluxation of your joint, olecranon, and then it's a fracture of your caput, the coronoid process. So you see a lot of these luxation fractures. They're like they are. Which one you get depends on a lot of factors, but it's something like there are a couple of these in the forearm, and it's important to think of these when you have problems going on with the caput of the radius, or when you have a solitary fracture, what you think is a solitary fracture somewhere in the forearm. Then you need to think of, could there be a fracture anywhere else, or a luxation anywhere else. And here you have the Essex-Lepresky, the radial head fracture with an central intraosseous membrane rupture here, and then you're with a drush injury as well. Yeah. And here's the Essex-Lepresky, where you actually need an X-ray of both the wrist and the elbow and the forearm as well. So sometimes you need the central X-ray, central way to go through all of these to actually do a decent assessment, because some of them might be subtle. Yeah. So one of the take-homes here is, like, if you have a caput radii fracture, always look carefully on the forearm clinically and see if there's might be any other fractures or dislocations. Okay. Then we get to the soft tissue injuries, and we already talked about the distal distal biceps tendon rupture. It has to be operated on within 2 to 3 weeks. After 3 weeks, the tendon will be hard to get right again. Sometimes they might have these Popeye sign, where you have a big muscle belly on the upper arm, but not always. And that's why we have to have a high index of suspicion if there's a flexor defect in the forearm after someone, usually a young person, have lifted something heavy or suddenly been yanked by something heavy in their arm, so that it's gone off. There might be ecchymosis on the area of the forearm here, but this is one of the it's in the database of often missed in EM cases. So I guess it's not always obvious this. They will usually have a worse, they will have a reduced supination or pain with supination because the biceps is also partly a supinator. Yeah. Then you also have your tricep tendon injuries. These are a bit more uncommon. They should be operated on within 6 weeks. It's usually young muscular men also fushing in hyperextension, so that it's just going the other way. They might have pain in the back of the elbow, and they might have felt a pop, and they will have extensor defects or be weak at extension. Then we go to common elbow fractures. You have your olecranon fracture. Again, here you check if whether or not there's an coronoid process involvement. If there is, then it's an unstable joint, and then it's something that you have to work up or maybe have to operate on. But most of these have to be managed conservatively. They do quite well and just needs rehab, especially if they're older, which most of them are. Then you have your isolated proximal radius fracture, and it depends on whether or not they're dislocated. If they're dislocated, then sometimes you need to operate on them. I think there's this 33-3-30 rule. If it's more than 30 degrees, if it's more than 3 millimeters of displacement, and if it's more than 33% of the surface, then you consider operation. If it's not dislocated, then it's almost never operated on. But you need to check for other fractures in the chain, as we talked about the coronoid fracture and luxation, the terrible triad, the Montegia with an ulnar fracture. That's usually if it's more like dislocated, but all right. And then the SX Lopresti. Okay. Yeah, we talked about these problems with the forearm. It's almost always operation, unless it's if there's a shortening. So usually you need to operate on the forearm. Okay, so now we'll move on to the exception where we often don't have to operate, and that's the distal radius fractures. There's a couple of these, and they always have eponyms, and I think we're moved beyond some of the eponyms now, but I'll just show you these. This is the radius, right? And if it's dorsally tilted or angulated, then it's called a Colles fracture. I think usually you have to have some kind of involvement of the styloid of the ulna as well to be totally precise, but we usually call it Colles fracture or a dorsally angulated radial fracture. These are 90% of all the fractures of the distal radius. Then you have the Smith fracture, which is the opposite. It's a volar angulation or volarly displaced radial fracture. And then you have this important one because this is a Barton fracture. The Barton fracture is a fracture that goes intra-articular. And these, the Smith and the Barton, they are always, or quote unquote always, like almost always operative. Where the Colles, it depends. And there's, I would go into a bit of detail with the Colles through the Swedish guidelines, the new Swedish guidelines that have been posted, because they're quite detailed and quite good, I think. All right, so the ones that are almost always operated on are the Smith fractures, the Barton fractures, because they're intra-articular, and then often the comminute fractures are almost always operated on. And these are like, if you remember the bad fractures in the beginning of this lecture, good versus bad fractures. Intra-articular is a bad fracture. Comminute is a bad fracture, right? All right. So the Colles fracture is 90%, and it all depends whether or not you should operate on it, or it depends on their function level. So if they have a high function level, then and that is defined by heavy compressive work every day, then it's quite easy. Then they should be operated on usually. Then it's these criteria. Then when it's a low low function level, then usually you don't operate on these. Also, usually easy, and that's like nursing home patients. They only operate if there's really gross displacement and or neurovascular compromise. So the hard one is the medium one, where you have to measure a lot of stuff. The high, you think about something. There are 3 measurements in the Swedish guidelines that they look at, and we'll go through these in a little while. Then there are certain complications to these. You always have to think about the Druge injuries, but they can be hard to pick up right away. So if someone fush and they still hurt after a while and there's no fracture, then you have to think of the Druge and the EPL injuries. I don't want to go into those. It's important to inform the patient that you will not get the totally same joint. There might be some stiffness that persists. All right. All right, so these angles. There's the dorsal angle tilt, which is the first one here, where you take this point of the radius and this point, the radius on the lateral side. And if the normal is -2 to -20, if that is below 20 degrees, then in a high functioning, that's all right. That's acceptable. But if it is a medium functioning, then you accept up to 20 degrees angulation. The radial inclination, that's in the AP film. You have, again, you take this point, so this point of the radius and this point of the radius, and then you measure the angle, and here you accept normal is between 19 and 29, and here you accept 15, and it should be high, this. So if it's compressed somewhat, then you accept more compression here. And then you have the ulnar variance, which is same 2 points, but now you measure the length, and it should be below 2 millimeters here, but if it's here, you accept below 3 millimeters. Okay, so again, you can maybe feel I'm no expert in these, but these are the measurements, and this is how you measure them. So check out how your local guidelines are. The Swedish, these numbers are from the Swedish guideline of radial fractures posted in 2021. Okay, so moving on to the shoulder region, the second to last region that we're going to talk about. And let's just get right on with it. Okay, so the shoulder, as you might know, sits here, and we'll go through the anatomy next here. So the surface anatomy, as we showed on this picture before of my shoulder in a somewhat axillary view. We have the clavicle going out here. We have the scapula, the spine of the scapula here, and then you have the processes choroideo, so the choroid process. And you have the acromion, the AC joint here, and then you have your humeral head right here. And this is the soft spot that you might use to inject with steroids in the shoulder or other stuff. Okay. Let's zoom in on the bony anatomy of this area. So we have the humeral head, which articulates here in the glenohumeral joint, what you call the labrum here of the glenoid. And you have your processus coronoid process. You can see through this picture, you can see the scapula here, and you can see the acromion up here, the spine of the scapula, and then the clavicle, and the same thing here. You might think of the shoulder region only having one joint, but there are several joints here actually. The joint with the which gets the most praise or most attention is usually the glenohumeral joint, and we'll talk about this joint because it's quite a unique joint in the body because it's so mobile, and because it's so mobile, it only articulates with a small part of the bone here, the humerus, and this mobility uh, is something that is hugely important for us, right? Evolutionary, but it has a catch, and the catch is that it often dislocates, or is prone to dislocation. It's prone to a lot of problems, as we'll go into. You also have the other joints here, the joints of the clavicle, the sternoclavicular joint, which we'll talk about, and the AC joint, which we'll also shortly talk about. And then I guess you have a joint here as well, and sometimes the joint here is also mentioned, but these are not as important. These are the three joints that are usually clinically important, at least. And then, of course, we have to talk about the rotator cuff muscles, but I'll just and the rest of the muscles of the shoulder region. And clinically speaking, I think the deltoid is not here, but the deltoid is the big mover of the shoulder, and the rotator cuff muscles are thought of as mainly stabilizers of the shoulder joint, acting as making the humerus fixed so that the deltoid can move. We talk about it acts like a fixed fulcrum, so that it can act like a fixed fulcrum for the deltoid as a primary mover. But we'll go into that in a little while. I have to be honest. When I did this research for this video, I find it so hard to know how to actually attack the rotator cuff, or how to approach the rotator cuff, because as an emergency physician, I didn't think I needed to know that much about it. But it's in all the curricula, in the Swedish curricula, in the English curricula, and in a lot of detail as well. So whether or not you think that you need to know too much about it, I think I found it like this. If you want to know something about it, you actually have to know quite a lot to be able to use it clinically. And I'll do so it became kind of a Pandora's box for me. So I'll give you the my take-home messages later on the rotator cuff syndromes, because it's a spectrum. But we'll move on. And for now, just say that there are some muscles called the rotator cuff. There are 4 muscles, and it's a continuum of muscles. It's not actually in the joint. If you look at the axillary view, or do an arthroscopy, you'll actually see that it's just a continuum of muscles. But when they move out, then you can see that they separate. Yeah. Okay, so moving through our scared off, of course, you can have septic arthritis, but it's not as common. Your compartment syndrome is less common in this region because of more space. Your non-accidental injuries, we'll just skip those, but there are some common fractures in this area when the child is being held or thrusted in certain ages, where you can get humeral breaks or rib breaks. This is important, I think. If you have someone complaining of elbow pain or shoulder pain, and you cannot reproduce it in any sort of way, not with passive movement, not with active movement, not with palpation, then you should really think that this may be a referred pain from somewhere. And there is a few areas of referred pain that are quite important for the shoulder region, and one of them is ACS, right? It can come from the heart. There's definitely in the literature a couple of patients cases being described, among other, by Patrick Croskery in his cognitive bias book, the cognitive autopsy, he mentions a case like this where ACS was missed because they didn't consider that if you cannot reproduce the pain that the patient is complaining of by palpating the limb, then it's probably a referred pain from somewhere else. Okay, and that in that case it was ACS. There are a few other regions that might be relevant here. It might come from, if you know of the, I think it's called the current sign. In the left shoulder, you have, if you have someone with pain in the left shoulder and a trauma of the abdomen, you should think of what? Well, you should think of a spleen having ruptured with referred pain to the shoulder. And on the right side, you should think of gallstones, right? Or biliary disease, referring the pain to the shoulder. Okay, so there's a few referred pains here that we should always think about if we cannot reproduce the entirety of the pain that the patient is presenting with by palpating the shoulder. Okay, so dislocations. You have your anterior dislocations and you have your posterior, and these are usually the ones. The scared of mnemonic, as we mentioned, is actually a mnemonic of if like occult things, like if the X-ray is negative, what then? And it comes from Aaron Sayal, right, where he sees that the patient gets the X-ray even before they've been examined, and when you, as a physician, sees the X-ray and see, oh, it's normal, the X-ray has already been done, I don't even have to examine the patient almost, then this is how you this is where this scared of especially fits in, because no, you have to actually examine the patient. The X-ray is not everything; it's Bayesian thinking. So you actually have to think of what is the pretest probability of all of these like things that can be bad if the patient has pain in this case in their shoulder, but don't have any findings on the X-ray. And the anterior shoulder dislocations, the main reason we miss those are usually if you don't order the X-ray. But the posterior ones, they're quite tough to find, and I think it's like 50 or 80% are usually missed by the first physician, according to EM cases. So yeah, posterior dislocations can be tricky, and because they don't feature they're not that common, and they don't look like that much as opposed to the anterior. Okay, then you have your operative soft tissue injuries, and there's a couple of these. The biceps, distal biceps, but not usually not the proximal biceps, but the distal biceps because it only attaches one place, but the biceps attaches two places around the shoulder region, and therefore one proximal biceps tear doesn't do much in terms of functioning decreasing in the region. So usually you don't like common guidelines would say that you shouldn't do anything about a proximal biceps, but there might be exceptions to that rule. Okay, the rotator cuff, and we'll see why the rotator cuff is a bit complex when it comes to whether or not they should be operated on. Impingement is part of the rotator cuff syndrome, so I won't go into that. And usually the AC joint is never operated on, so it's not an operative joint or ligamentous problem. Occult fractures, I mean, it's not really occult. The clavicle usually it's quite obvious actually. But this is important. The nerve, the axillary nerve, is often injured, and it's usually the distribution towards the deltoid, around the deltoid region that is numb, and you'll have to examine all the three nerves very carefully when you have someone with a shoulder dislocation before and after reducing it. Okay. All right, some pearls from around the FOMED literature. It's like first one is like if you have rotator cuff injuries, and we'll talk about this as well, but usually there's a difference between the traumatic rotator cuff injuries and the non-traumatic rotator cuff problems, and the traumatic ones are usually the ones that you need to operate on, especially the young patients. That's kind of the take-home message. They don't need to be operated on right away, but they need to be operated on within a few weeks, usually depending on local guidelines. It's important when there's a fracture in the shoulder, like the proximal humeral fracture. There's this rule of thumb that EM cases give us, that the shoulder is going to be 80 to 90% good after around a couple of months, maybe 1 month or 2 months. But the last like 10 to 20% recovery will take 6 to 12 months, maybe longer, for it to be like for it to recover all the way. And it's important, like again, information for the patient is really important, and expectation management. It's important to know that you should not immobilize the shoulder. You get what you call capsulitis, right? A frozen shoulder, I think it's called adhesive capsulitis. And it's like, and the only exception to this rule that I know of is when you have someone with a shoulder dislocation, and you want to use this this problem that the shoulder is prone to stabilize the shoulder, actually. So I don't know about, it depends on local guidelines, but it's in literature that you should immobilize the patient for more than 3 weeks if they have a shoulder injury, a shoulder dislocation, because then you will get a more stiffer joint, which is more stable for someone prone to dislocations. I'm not sure how that goes into practice, but it's in the literature, and the foam ed literature at least. All right. And as we talk about, neurovascular status is really important. Because of this 1 to 3 weeks, it's really important already in the emergency department to actually teach the patient how to move, and like as soon as possible they should move, and they have to be decently pain relieved as well. All right. And the rest of the stuff we'll talk about. All right, examine the shoulder. Inspection. Usually, if you have a shoulder dislocation, it will be quite obvious. You can see whether or not what kind of position the patient is holding the shoulder in. If they're like the anterior shoulder dislocation, it usually comes in with a lot of pain or discomfort, especially if these, like the classical presentation, this young guy saying like, it's out, it's like they're kind of distressed. If this happened before, then they're usually not. But if it's first time or one of the first times, then usually they have like they're holding their shoulder, and they're like grunting and in discomfort. And they have this, what you call the épaulé shoulder, where you can see the oftentimes you can see the obvious dislocation. Other things that you might notice is that with the posterior dislocation, you can see that the patient cannot externally rotate their arm. It's enforced internal rotation, so they would not be able to externally rotate their arm. It's like mechanically locked. And with the erecta, the special case of anterior shoulder dislocation, you have the erecta, where they come in with a almost salute kind of, where you have your arm above the head. So the inspection of this is really important, and you can get a lot of clues there. You might also see like the clavicle, whether or not it's broken. Usually you might see tenting around the clavicle, and this is one of the few areas of the body where tenting is not that serious, and should not be. You don't have to reduce anything right away if you see tenting here. It's usually something that doesn't need any severe management. Yeah. We'll get back to that. Then you do palpation, and usually I'll do like systematic palpation of all the structures, from going from clavicle, as you saw in my surface anatomy picture, going from the clavicle, medial clavicle, out to the lateral clavicle, over the AC joint, to the acromion, over to the spine of the scapula, and then moving down into the humeral joint. Yeah, and as well checking for neurovascular status on the arm, especially around the deltoid region for the axillary nerve sensory region. Okay, and then it comes to the movement, and the shoulder has a lot of movement, and and especially when you have cuff problems, it's important to know a few of these special tests. Not that they necessarily are that useful in the emergency department. To my knowledge, there have never been any tests, like any studies in the emergency department on these. Usually, the special tests that we know, and I'll go through them, are not validated for the emergency department. They're validated for outpatient orthopedic office hours clinics. So it's a special population and it's a special location that they've been tested in. So, but there are there's a lot of these special tests. But like in general, the abduction is important, and you of course do the active and passive for these abduction as abduction and adduction. Um, um, and then you have extension flexion, then you have inwards and outwards rotation, which is easiest tested with the hands um, with the hand behind the back, or with the hand the elbow to the shoulder, and then rotating inwards and outwards. Okay. There's this table from Swisum's utbildningsmaterial, which where they dichotomize or kind of structure the shoulder examination in active movement, passive movement, and force. So and depending on the result of these three factors variables, you'll think of different things. So if you have someone with shoulder pain maybe, and you have unlimited active, like if you ask the patient to abduct and adduct, and they can do everything, and also unlimited passive motion, and the power is good, then you're thinking of these referred pains, right? Myocardial infarction, the spleen rupture, or biliary things as well, or maybe even cervical rhizopathy, which would be radiculations from the cervical root, right? You might do a Sperling's or a test there, and usually one of the pearls here is that if there's a radiating pain from the shoulder, if it usually should, just like with the knees, it should go below the elbow, like distal to the elbow. If it goes above the elbow, then it's usually something to do with the rotator cuff more so than it's to do with radiculation. Okay, these are rules of thumbs. Okay, there might be exceptions, but um, the common teaching is that rotator cuffs are like the radiating pain from these kind of shoulder problems usually go down to the elbow, but not further down. So yeah, okay. If you have limited movement when it's active, but by passive movement it's unlimited, but it might induce some pain, and you have you may or may not have decreased power, and we'll go back. So it might be rotator cuff syndrome spectrum diseases. It might be, especially like if you might have a tear if it's, as we will talk about, you might have a tear if the power is low. But if the power is intact and it's only pain, then like with a pain arc, then it's more likely to be impingement, bursitis, or calcifications, arthritis, something like that, in the milder end of the spectrum of rotator cuff spectrum disease disorders. Right. Of course, you might also have with pain, septic arthritis. You usually see other stuff like redness and swelling, but not necessarily. Of course, this is this is really hard diagnosis to get usually. But now you know where you should puncture the joint to be able to get a test. Of course, you might also think of this as radiculopathy, but it's usually the shoulder region should usually be your white radiculopathy. But this is more if you have pain. If you have decreased in power. Okay. Then you have if it's limited active movement, and the same here, and then you definitely have this. Then you may have, like, if it's really limited this, then you're further out on the spectrum of rotator cuff spectrum disorders. It might be a total tear, and then you would have you might have something like pseudo paralysis, where you cannot get your arms, like you cannot initiate the movement of the arm, and when you try to, then the deltoid will push the humeral head almost out of joint. Yeah, and you might have some of these other conditions as well. And then if all of it is limited, like active movement, passive movement, and power, you might have adhesive capsulitis. You might have luxation or a fracture. These are like really these are not set in stone. It's just a rule of thumb, but I think it's okay. It's an okay way to think of the conditions, because it's quite complex, this shoulder region. Okay. Moving on to the don't miss diagnoses, and one of this one is like a really dangerous one that you might not have heard of, but it's really rare, and usually it happens in motor vehicle accidents, like high energy trauma. Usually you can have a luxation both anteriorly, where so we're talking about the sternoclavicular joint here, and this is a posterior one here, but you can also have a where it goes anteriorly, and usually that would be if someone is pushing on the shoulder blade. And these are not as dangerous, but these are not dangerous. But the other ones, the posterior ones, are really dangerous, because there's lots of what you would call sensitive anatomy just behind the sternum, right? And this might be either destroyed or damaged if there's a posterior dislocation, and it's actually a life-threatening condition. So what you do if you have one of these conditions, it's usually a direct hit towards the posterior lateral shoulder, so behind here, and then so that the joint actually moves in. What you usually see is that there's swelling, and the patient might have difficulty swallowing because pushing on the esophagus of the trachea. They might have a dyspnea, stridor, and cyanosis as well, and you might have neurodeficits from nerve damage here. What you'll do once you see this is that you'll I'm not quite sure about what you'll do first. I guess it depends on the patient's condition. If it's, I guess if it's stable, then you might want to do the CT angiogram first. You will have to do a CT angiogram no matter what. If the patient is stable and relatively comfortable, and there's nothing else going on, then you might be able to just do the CT first. But what you do want to do is you want to get it back in place before it destroys more stuff. And the way we heard you should do this on the course was put a pillow, like a hard pillow, so a hard surface behind the patient's back, so that they're elevated, and then you'll pull down on the arm, so that the joint will pop up. Hopefully, you probably want a orthopedic surgeon with you while you're doing this. Yeah, these are really rare. and usually it's more high energy trauma where it happens. All right. Then we'll move on to the anterior subluxation, because we talked about the usual, like the dislocation, and subluxation is where it's not entirely out of joint, and this might be young women with high mobility, or and you will usually hear someone saying that, oh, the shoulder jumped out. You can do the apprehension test. The apprehension test here would be, think of how a like an Olympic javelin thrower, a spear thrower, throws. Like the arm is like pulled back, and in that exact like just before they're throwing, in that exact position, this is where you will see that the shoulder joint can pop out anteriorly. And if you push on the patient's shoulder in that position, if you push on the humeral head, and you pull back on the elbow in that position, that javelin thrower position, then it'll feel uncomfortable for the patient. I think there's a modified apprehension test as well, where you try to modify the patient's feeling of discomfort in this position, where you try to put a hand on the humeral head so that it cups the humerus, the humeral head, and makes it more stable, feel more stable at least, and that's I think that's called a modified apprehension test. I'm not sure, but if you have it's uncomfortable doing that, the apprehension test, and it feels better when you do the modified apprehension test, then you might consider that the patient has either an acute or a chronic problem with luxation. I'll show you in a little bit a picture of an analogy that is usually used for the shoulder joint. If you think about a golf ball and a tee, like the small tee that it's standing on, that's kind of, the golf ball is the humeral head, and the tee is the glenoid area where it articulates, and it's like it's quite a small area. And if just there's a small break in the glenoid, like with a bony Banker lesion, then the joint might be unstable, and you might be prone to these subluxations whenever you do the javelin throw kind of movement. And these patients usually need some kind of operation after an MRI to verify the diagnosis. Yeah. It's usually young patients that might have had one or two luxations before, and then they feel the shoulder popping out every time they try to do a certain movement. And that's, you might not see these in the emergency department, but you might, and now you know how to work them up. If there's this caveat, if they recently did the luxation, then you shouldn't. If they recently have a full dislocation, then you should not do the apprehension test. Usually, that's what the textbook says, because I guess you don't want to create more instability, and you don't want to iatrogenically dislocate the joint. And also, it might be falsely positive, because if it just went out, if it was just dislocated, then it will feel uncomfortable no matter what you kind of do. So the apprehension test might be falsely positive. Okay, for the posterior dislocation or luxation of the shoulder, in general, you have 3 E's: the energy or electricity, ethanol, or epileptic seizures. That's like also a textbook thing, but that you should consider for the reason why they had this dislocation. Usually, the one I've seen was an epileptic seizure. So epileptic seizures is usually is a common cause of this. These only make up of 10% of all shoulder dislocations, and 50 to 80% of them are missed at the first visit because they're quite hard to find, both on X-ray and clinically. All right, but one of the key things are that the arm is locked in internal rotation, and if you try to externally rotate, there will be like a mechanical stop. That's the key thing to actually think of when you have to then you have to think of the posterior dislocation. I'll show you the X-rays, the X-ray findings in the next slide, and you'll treat it with, there's different techniques. You can check out the EM Cases Rapid Review for shoulder dislocation, where they have a 9-minute video going through all of this. But in general, the Cunningham technique can be used here. And when you've gotten it into joint again, then you'll have to immobilize it in a special way, at least the current, or according to EM Cases, but check your local guidelines. Okay. All right, so for the anterior, for the posterior dislocation here, you have something called, on the X-ray you might have something called the Thruth sign, not the through, but Thruth sign, which is it's a what you call a reverse Hill-Sachs lesion. Hill-Sachs is usually a lesion around this area on the humeral head when it like banks up into the acromion, and usually seen on older people. And I guess the reverse one is something that is created here in this area, and where you'll see like this dent. I think it's more. It might be a bit clearer on this picture, where you also have the light pulse sign, which we will show you in a minute. But you have this like more rough area here, Thruth sign, Thruth line sign. Okay. Then you might have a increased distance between your glenoid and the humeral head, and above 6 millimeters is enough to say that it's posterior dislocated. And then you have your light bulb sign, which also might sometimes look like a chicken wing, where the humeral head kind of looks more round than it should. I mean, if you're not used to looking at these pictures, and I'm certainly not an expert at this, but this is how it should look like. It should be rough on one side and it should be smooth on the other side. But if it's totally round, it's because then you have to think about posterior dislocation, right? And some people things look like a chopstick, a chicken wing, and some people things look like a light bulb. Yeah. So these are the things that you might look out for posterior dislocation. But you might appreciate that it's easy to miss some of these, and that's probably why some of them also are missed. Besides not even doing the X-ray, right? So. All right, and here was the link for the video of the EM cases where you can see, where they go through the shoulder injuries as well, shoulder dislocations. Okay, moving on to the common ones. So one of the common things we often see are clavicle, and there's quite some nuance to the clavicle fractures. It's usually it's one of those things that in Denmark we usually we see if it's like a injury where you fall on your hand or fall on your it's like a soccer injury, usually it's football injury, and usually it's one of these like mid shaft mid shaft undislocated fractures. That might be dislocated or undislocated, and sometimes the dislocation might be quite severe, and that's one of those things. It might be quite displaced, but they almost never need operation, or it's at least it's complicated, and it's a discussion worth having with the patient, but not for the emergency physician, but for the orthopedic surgeon, because the benefits and harms are at like kind of the same somewhat. All right, so in general, this area of the body, there's really thin skin, and there's the benefit of operation is usually that you can get if you have a clavicle fracture in this area. It's usually that you will get get going faster. It will heal a bit faster, but there's a somewhat high infection risk in this area. And usually, like when you look at follow-up studies through, I don't know, a couple of maybe 1 or 2 years, then I think it's 2 years, yeah. Then the benefit between the operation group and the non-operating group has been planed out. So it's there's no, when you look 2 years after, there's no benefit of operation versus no operation, because the function level is the same, even though the fracture might look like this. It's still this kind of the same. And one of the problems besides infectious risk and besides going through an operation, is that usually the plate needs to go out because it's rubbing on the skin, and the skin is quite tender and really thin here. So that's why usually you'll have to go through another operation to remove that after a while. So it's really up to a discussion with the patient, and usually that has to happen if there's a severe displacement. Then you will do that. All right. You might see tenting, and if you do see tenting, then I've seen different guidelines for what to do. If you do see tenting, some will put a bandage over this. Our course director said that we should probably do nothing about it. Just sterilize your area and maybe suture up the skin if it goes through. Look for neurovascular injury, of course, and rarely you can see pneumothoraxes and so on with clavicle fractures, but usually it's really rare. If it's undislocated, if it's just in line, then it's usually you can move as much as you want, depending on your pain level. You will have 2 weeks of pain, but after that it will become better. And it's only like these it's only these dislocated like this on the picture, where you need to follow them up after maybe 7 to 14 days, and then an orthopedic surgeon has to have the conversation with the patient whether or not they want an operation. Usually they shouldn't, but sometimes they do go for the operation. Especially if they're working, then you might want that faster healing time. Is beneficial if you're really working and you need to go back to work. But just to say, like, they usually heal good anyway. It really has to be really displaced. Like, I think there are certain criteria for when there are too displaced, but even if they go through the skin, I think it's not something that is necessarily operated on. It'll usually heal all right anyway. But yeah. All right, the lateral ones and the medial ones, they are usually managed conservatively, unless they're intra-articular, and they're quite rare, or rarer at least, and usually happens in older people. This is what the Danish KKR, the quick clinical guideline for Danish orthopedic surgery, says about this. So the treatment of dislocated mid-shaft clavicular fractures in adults should primarily be non-operative, as there's not been shown any benefit after 1 year when you after 1 year, like operative versus non-operative. Operative treatment increases the chances of healing and probably functional level in the short term, but not necessarily in long term. And also there's a documented risk of infection nerve lesions and vascular lesions, and a big need for, as we talked about, reoperation of the osteosynthesis material, getting that out because the skin is really close to the skin. So there's quite a lot of risk involved with the operation, especially, and many don't want to take that risk. Yeah. So that's the clavicle. Humeral fractures, I think we talked about them earlier, but just quickly. It's usually the proximal humeral fractures that we will see. And usually it's important to tell the patient that, like what we talked about before, like 90%, it will feel 90% good around a few months in, but the last 10 or 20% will take 6 to 12 months, maybe longer, before it feels good. Mobilization is important, really fast. You might do pendulum swings or wall walk-ups, and should avoid immobilization beyond 3 weeks, especially because they will develop frozen shoulder. In general, they don't, like, as a rule of thumb, they don't need operations either. These EM cases have a few criteria for when that you might consider operations. A lot of them is the same as the bad fracture, kind of Arun Sayal's mnemonic with the 4 criteria. Like it. So let's see if it's comminuted, there's a higher risk of the needing to operate on it. If it's displaced, especially if it's so displaced that there's a risk of avascular necrosis. If the major tuberosity is displaced, then the joint might be compromised, and then it might be there might be a need for operation. And if the head is split open, then there might be a need for operation as well. Always test the neurovascular status, because there might be compromise there as well. And treatment is usually 14 days in a sling. Use the arm as much as possible. And it's important to tell the patients, like, basic stuff, how to do basic stuff. Just like when you need to bathe, you can't really use the arm, but you should lean towards the side so that you can let your arm hang down when you're washing your axilla. And when you're sleeping, you should sleep with a pillow under your arm so it doesn't hurt. Like, these small tips are really important for the patient. Okay, this is what the Orthopedic Surgery Society says in Denmark about these kind of fractures. They say in 2020, no studies of moderate or high quality has been found has found any clinical or statistical relevant difference between surgical or non-surgical treatment of the displaced proximal humeral fracture in elderly. And young patients, will get to those here. We therefore recommend that these fractures, as usually as a rule of thumb, should not be treated surgically. So that is for the elderly patient, and I guess biologically elderly. In the included studies, there are patients with displaced 2, 3, and 4 part fractures, and it's possible that other fracture types, as luxation fractures or split head fractures, as we talked about here, as well as younger patients, may have a benefit of operation. So the younger patient is usually considered for operation, or especially if they have any of these criteria here. If the older patient is usually managed conservatively. That's the takeaway here. Okay. You have different kinds of humeral fractures as well, besides the proximal humeral fracture that we just went through. You have the diaphysis, or the shaft humeral fracture. These are often segmental and will heal bad, and usually they need operation, right? And you have your supracondylar, ones, and it's really important these that they usually have, or not rarely have, a radial nerve damage, like they have a drop hand. And the good thing about this is that usually it's important to tell the patient that usually it becomes quite good, the radial paresis, after rehabilitation. So it's not this is one of these nerve damages that actually becomes really good by conservative management, as we were told, at least by our course managers. Also, you need to test the arterial brachialis because it might be off. These are often spiral fractures, and there's a special kind of fracture here called the Holstein-Lewis fracture, which is managed conservatively, almost never operated on. But it's important to tell the patients that it's a hell. With you can't really do anything, and it's 2 to 3 weeks of pain, but it will be good after that. Yeah. Then you have your distal humeral fractures. Also, they don't heal that well, so they should be operated on as well. Then you have your anterior luxation, and we went through a lot of the anterior luxation before. Like the main points are these might also be epileptic in reason, but in cause, but they might as well just be traumatic in other ways. 90% of them are these are like 90% of all dislocations, so you will see a lot of these. You always have to do the neurovascular status, of course. And there's a few what you would call it, features of the on the X-ray that we need to be aware of. I'll show you these on the next slide. It's the avulsion, the Hill-Sachs deformity, and the bony Bankert. The first two are usually seen in elderly, and the bony Bankert is often seen in the young. And the bony Bankert is especially important for the young because it might create this unstable joint where you need to operate on them to get the joint to be stable again. And that was what I was referring to when we had these patients that might be apprehension test positive after a while, and they feel like subluxating their joint every time they do the javelin thrower position. Okay. Usually, we talked about how to reduce these in the start of this in one of the earlier parts of this lecture, so I won't go through that. But the management is usually don't do any heavy lifting for 6 weeks. You might but check your local guidelines for the treatment here. Okay, so what you might see here when you do the X-ray, and I guess you should do the X-ray before and after a reduction, with the exception maybe if the patient has a non-traumatic dislocation, then you might skip the X-ray. Like if and it's happened before, like if a patient just stretches and then it pops out, then you probably don't need an X-ray. But in the traumatic ones and the first timers, you need an X-ray before and after. Okay. This is a avulsion. It's common in the above 50 population, elderly and middle-aged and elderly patients, and usually they are quite well managed by just popping in the joint, like reducing the joint, and then it'll pop back, and usually doesn't need to do anything else with it. The Hill-Sachs lesions is a lesion here, where it's like an impression fracture where the humerus is going up against the acromion. There's also often older patients. It's like, and it happens to 50% of all the anterior luxations. And the large ones might require surgery, so it's important to keep an eye out for these. And then you have the bony Bankert lesion, and these might be quite subtle. It's a and almost all almost all dislocations will get some amount of bony Bankert lesion, but the big ones are the ones that needs to be fixed. It's a syndrome called TUPS. I can't remember what it stands for, but it's like you have an unstable shoulder, and we talked about that the shoulder, the humeral head, articulates with the glenoid, and it's kind of like it's a very small surface area, and if just there's a small chip going off here, then the ball might often easily roll off, and that's why like just a small lesion might give a huge problem for the patient further on, where you have to like treat this by doing an MRI if their apprehension test positive, and they often like feel like they're subluxating their arm. Do an MRI to verify the diagnosis, and then consider them for operation. Okay. Then you have your luxator erecta. I think we're at, this should have gone in the uncommon section because it's really uncommon. It's less than 1% of all the dislocations. It's really important, even more important here to do the neurovascular status, because 40% of these will have vascular injury and 60% will have nerve injury. It's quite hard to miss because they have their arm in this salute kind of position or erect position, and it's usually managed operatively. It might be managed with a zero position reduction technique, but depends. And these are rare cases, so I'll usually call in a surgeon for these. All right, moving on to the Pandora's box here, the soft tissue injuries of the shoulder. Okay, here we go. So this is my small mini talk on the rotator cuff syndrome and shoulder pain, this deep dive. And this might be more than you think you need to know. I think it was quite hard to comprehend the shoulder soft tissue injuries without getting a bit more detailed, because when I tried to not get too detailed, it seemed like it was not good enough. so that's why I've ended doing this mini lecture in the lecture here about the rotator cuff syndromes. I'll suggest going to Orthobolus especially, and there's this great video on Orthopedic Principles YouTube channel, Rotator Cuff Disease. Check that out. And then Andy Neal, again, The Anatomy of the Shoulder is really good. Yeah. All right, so why is the rotator cuff important for us to know at all in emergency medicine? Well, as I understand it, the rotator cuff syndromes are actually two kinds of animals. There are the like kind of the traumatic ones, which has a different prognosis and different mechanics usually than the degenerative ones. And the traumatic ones are the ones that we would usually see. So the traumatic ones are often considered for operation because they decompensate faster, especially if it's a young patient with a traumatic rotator cuff lesion. We might not be the ones to be able to diagnose these because it often happens with anterior dislocation of the shoulder, and we might not be able to actually pick it out because of their pain. But if they do have, even if we pick it out or we are aware that this is a problem, then we'll arrange for follow-up with the specific question of rotator cuff tear or rotator cuff syndrome. And if that is found, they should probably quite fast, and it's hard to gauge how fast according to the literature, but quite fast, within a couple of weeks to months, they need to be considered for operation. Okay, and I think the upper limit of that is 6 months. After that, the tendon would be too retracted, and the muscle would be replaced somewhat with fatty infiltrations, so that it cannot be operated on, and they will lose that kind of shoulder movement. And that's a big problem for the traumatic ones, not as much for the degenerative ones as we'll see. All right. So back to this picture, the rotator cuff is 4 muscles. There's a supraspinatus, which initiates abduction and is thought of as a humeral depressor, and I'll talk about what I mean by that. Then you have and the test, the special test we'll go back to are not that good, but the one that usually is set here for this is the Job's test or the empty can test, which is the same. All of these tests try to isolate one muscle, and it's part of their problem because it's quite hard. to isolate one muscle in the movement. But then you have the subscapularis, which does internal rotation. It's a strong internal rotator, really important for that. And the classical test for that is the lift off behind. If you do the behind the back, like you tell the patient to have the arm behind the back, and then you press the arm, and the patient presses the arm off the back. Or the belly press is the same, just pressing the stomach and see if they're using. Then you look at the arm and see if they're using the arm or they're actually using their hand for internal rotation. So if they're losing their arm, then it's a positive test. And then you have the teres minor and the infraspinatus, which are usually talked about together because they kind of do the same thing, and they're external rotators. And the test here is just to externally rotate against force with the elbow on the side. And each of these tests are weakness tests. Like they test for weakness in particular. And as we will see, they have like each of these tests have a lag test. Like this is an active movement test. You try to move against the doctor, trying to hold the patient in the position, like the external rotation. Then you move towards external rotation. Like you move, the patient tries to actively externally rotate their arm, and the doctor tries to hold against that. And then you have to gauge what amount of, like, how painful, especially how weak the arm is. But it seems like as I'll show a study done in JAMA, a comprehensive review of these tests, it seems like the lag tests, the lag version of these tests, where instead of trying to press against the doctor, then the doctor tries to get the muscle in the extreme compression state. So, for instance, with the lift-off test behind the back, you try to let the patient lift their arm off the back as much as they can and try to hold it there. And if they lag, like if they lose their arm, then it's a lag test positive. So that all of these tests have a active test and a lag test. And it seems like the lag test, according to these studies, are actually better at diagnosing tears, right? As we will see, tears, like in the rotator cuff spectrum of diseases, pain is usually like impingement or bursitis. Tears is usually weakness, right? So and you have different tests for different things here. So these tests are mainly weakness tests for tears, right? Okay. So there's a couple of concepts that are somewhat important to understand in the rotator cuff. So the deltoid muscle is the primary mover, like especially in abduction, abduction of the shoulder. But it has to work against a fulcrum, and the fulcrum is the humeral head, right? And if the deltoid is moving unopposed, then it'll just dislocate the humerus. Then the fulcrum is not fixated. So what the shoulder actually does, and especially in this view, the suprascapularis muscle, sorry, the supraspinatus muscle, and the rest of the rotator cuff, they kind of pull down the humeral head as well. Like they fixate they're an opposing force, so that this force and this force together makes a fixated fulcrum, and that fixated fulcrum makes the joint being able to move quite smoothly. So if this moment arm is if there's a cuff tear, then the deltoid will just dislocate the humeral head. It might be easier to see in this picture as well, where it's called coronal force decoupling if you want to look it up. But when when you need to like abduct the shoulder, for instance, then you have to then the deltoid muscle will move. But here you can see if there was no force pushing the humeral head into the glenoid, then the deltoid movement will just subluxate the humeral head and not move that much, leading to usually pseudoparalysis in the patient. So what the a lot of the function of the rotator cuff muscles are to fixate the humeral head, so what you call the fixated fulcrum. Okay, so the deltoid has something to move around, and so let's go on to this spectrum. Okay, so the rotator cuff spectrum or syndrome should be thought of as like the beginning here, where you have a normal shoulder with bursa, and you have your deltoid, and you have your supraspinatus, and you have your normal joint, right? Then impingement or bursitis or calcification are kind of the same ballpark, where you develop pain. And usually you have what you call a pain arch that is positive, and we'll go into what that is. But this is like the hallmark of this is pain, and there might be night pain as well. That is usually more advanced, but usually it's pain radiating down into the elbow region, but not beyond. The next step here is a rotator cuff tear. And here we're talking about degenerative. We're not talking about the traumatic, because you can get a tear just by like trauma, but we're talking about like the pathological sort of nature of the development of rotator cuff tears. And if a tear develops after these processes, then you'll already have the pain from these kind of processes, but then on top of that you'll have weakness suddenly because of a tear, and the weakness is partly because of the entire muscle is not working probably properly, but it also is because like the fixated fulcrum is somewhat not working optimally. And then you have the last part. Sorry about the picture, but what the X-ray should be showing is that you'll have a you'll begin to show X-ray findings of humeral head being knocked up into the acromion, and you'll have degeneration of the entire area as if there are total rotator cuff tears, because the deltoid is working unopposed against nothing, and then it's just subluxating all the time, and usually you have pain, weakness, and humeral displacement every time you try to abduct your shoulder. Yeah, so think of this. Don't think of impingement as an isolated syndrome. It's usually part of a spectrum, right? Beginning with this. I think there's some controversy on why some develop more quickly and why, and so on and so forth. As we'll see, it's somewhat normal for above 60-year-olds to have tears. I think one third of all above 60-year-old patients have some kind of tear in the rotator cuff, and I think this goes up to above 70 years old is like 2/3. Yeah, but don't think of tears as one isolated thing. It's a spectrum moving on through your lifetime, and through with different risk factors, which we'll go into. And when we go to the testing part of the rotator cuff, then these impingement syndromes and so on, the tests that you're mainly doing here are what you call provocation tests. This might be just do an abduction and see if there's a pain arch. You might do what you call a Near's test or Hawking's test, trying to like catch the area where it's hurting. And as opposed to these tests, then you have some more strength orientated. Even though these might also induce pain, these are mainly strength orientated tests. As I went through before, it would be the external rotation test. It would be like the behind the back or belly press test. And it would be abduction test of the cerebrospinatus or empty can test and so on. These are mainly testing for weakness, but you will test for pain and weakness with both tests. But some tests do this better and other tests do this better. Okay, there's one concept that is somewhat interesting to know about, even though it's a bit detailed. So this is a concept developed by a orthopedics professor, I think, called Burkert in '93, called the cable crescent theory. So you could think, and I might be butchering this concept. I'm no expert in this, but as I understand it, the if you look at the a lateral view here of the humeral head and where the muscles attached to, then you might think of the muscle attachment as a bridge and one of these suspension bridges. And in degenerative diseases, you will have a sagging of this area, like you'll have a sagging like this. And that doesn't matter that much because you have the pillars of the bridge actually being quite strong and being able to compensate a bit more. So it's not as quickly deteriorating the degenerative tears, but a traumatic tear will destroy this bridge oftentimes, and it'll decompensate the entire area much more. So that's, as I understand it, that's the difference between the trauma and the degeneration. The degeneration, the bridge can kind of compensate for. The trauma is detrimental and will destroy it, meaning that you often have to operate on the trauma, but not on the degenerative part. All right, a bit more theories here. So why do some people develop this and others not? Well, there are two theories. There's the extrinsic theory, which can be thought of as, well, the tendon is normal, but it's the action upon the tendon that is problematic. So accumulative compression, often from work with above your head, like if you're a painter or a decorator or something like that. Then there will be continuous hyperabduction, and that this will catch the tendon, and it will be inflamed and by this developing impingement, and then later on it'll be more brittle and might be at risk of tears. Okay, so that's the intrinsic theory or hypothesis, I should say. And you have your intrinsic hypothesis, which says that, well, the tendon is weak. It's not normal, it's weak. And that might be because of age-related hypovascularization, like, so it's an age thing. It might be something about hormones, and males develop this more than females, and so on and so forth. So just to say that these are the two, I guess, hypotheses on why we develop these things. They are mutually synergistic, so it's probably both. And there might be other stuff as well. All right, so the two kind of patients that you'll see with RC spectrum disorders are, in the emergency department at least, are the traumatic tears, from dislocation of the shoulder, and then you might see the non-traumatic degenerative tears, and this would usually be your older patient, and this will usually be your younger patient. But the older patient can also, of course, get these traumatic tears. Okay, for this patient, there's almost always an operation. You just need to have to write them up for an operation, or you have to get them to somewhere where they can get an operation, and that's why we probably, as an emergency physician, need to catch these a bit early on, so that they don't go too long. Okay, and for these, it's usually like this. They can be managed non-operatively. and that's usually the case. But they can also be managed operatively in rare occasions, or in rarer occasions if the non-operative treatment has failed. But the traumatic ones are usually operated on, depends on the patient factors, which we'll go through here. So the non-operative treatment, first, it's usually rehab for 6 months, and then it's if they cannot do the rehab because of pain, then especially you need the injections. The injections should be thought of as a bridge builder, so that the rehabilitation can happen, not as a fix in itself. Okay. There might be some patients that are too frail to actually go through with anything, where the injections might help as a primary treatment, but that's more unusual as I understand it. And if the rehab doesn't work and the injections stop working because there's the first injections might work, but then there's a kind of a law of diminishing returns. As the more injections you get, the less they work. Then some will go on to operation, but it depends on the surgeon and so on. A few things to know, and it's really important that it's really a normal condition to have some amount of tears. So when you do the MR, if anyone has done an MRI on them, it's much like with your back pain. A lot of patients go around with prolapsed discs, herniated discs, and the same thing here. A lot of people go around with tears and are asymptomatic. Okay, so it's all about context. It's all about pretest probability. Just like in neurology or any other specialty, does the lesion add up with what the patient is presenting with the symptoms and the weakness, or is it are there shoulder pain because of something else, right? So you always need to think about the context when you're making the decision to whether or not not admit, but send these to orthopedic surgery. Okay. Some sources like orthobullets and some of the lectures that I linked to, they would say that the asymptomatic patients will progress to being symptomatic within 2 or 3 years if you see a tear in these studies, which is not the same for herniated discs in the back, so it might be a difference here. Okay, so the factors that count for operation is usually if it's traumatic, right? Because that bridge theory, it destroys the bridge, being the traumatic rotator cuff injury, especially if they're biological young and if they're working, and they need to go back to work. If they don't have any healing problems like diabetes or smoking, and if they're motivated, it's important to tell the patient that it's not a quick fix. It will take 6 months in a sling after operation, and then it will take 6 to 9 months of rehab, and the shoulder will not be normal in this entire time. So it's like you don't have a normal shoulder for almost a year when going through the operation. Can you deal with that? It's not a quick fix. All right. And it also depends somewhat on what kind of tear it is, and I won't go into detail with that because that's more for the orthopedic surgeons to know about. But and then you have what you call it also depends on how long, especially for the traumatic ones, right? How long has it lasted? And what they look at on MRIs, I think, is how much fat are there in the muscle and how retracted is the tendon. Because if it's really retracted, then they cannot reattach it. It'll just be brittle and you cannot. It's too hard to reattach it. And if it's too much fat, well, then there's not much muscle left to recover, right? So, and for traumatic lesions, it's 6 months usually is what is said to be the upper limit. Okay. All right. So when you do your tests, then it's really important to distinguish between, is this a traumatic lesion or a non-traumatic lesion, because that's one of the main things that are important. Okay, so when you do, but clinically, if you have someone with shoulder pain coming in and it's not traumatic, then usually it's shoulder pain, like with radiation around the deltoid region, maybe down to the elbow, but not any further. If it's further, then you should think about, as we talk about, radiculopathy from this cervical spine. And sometimes there's also periscapular pain, like towards the back. You can ask the patient if the pain is worsening with like normal everyday movements that might activate the rotator cuff, such as over the head work, like working with your hands over the head. If they're combing their hair behind the back, like in the hair on their back of the scalp, or if they're taking off the bra if they're women. Or cross-dressing male. So this is what you might. So the pain, as I said, that would be impingement syndromes on the like the left part of the spectrum. If you remember the spectrum, that would be solitary pain would be bursitis calcification or something like that on the left side of the spectrum. Then if it progresses to weakness, then you might find weakness in any of these tests that we're going to go through, but they're not that specific, and so we'll go through that. And if it's really bad, you might see pseudoparalysis. You might see this in a total rupture in a traumatic patient, and if you see that, then it's usually quite fast. They need to go to operation, not today, but within weeks. And what you might see is that there's this fixed fulcrum is totally out of place. There's nothing opposing the deltoid, so the deltoid would just move almost soft-luxate the humerus every time. So it usually looks like this. You'll tell the patient to keep their arms above their head, but they can't, and you'll see that every time they try, the deltoid is trying to move the humeral head up. Okay. Then you have your special tests that you might want to do besides your normal examination of the shoulder. And the test you want to do is the provocation test for pain, and then you have your weakness tests as we will go through. And you might do an X-ray. And there might be what you call, like even at the very left of the spectrum, you might have what you call impingement sign. It's like, I think it's a bit more white on certain areas of exposure on the X-ray, but you can look that up yourself. And then the MRI is something that should always be viewed in context, because so many at baseline have tears when you get up in age. Okay. All right. So here are some of the general tests for this. By general, I mean they don't try to diagnose any specific muscle. They just try to see, is there a problem with the rotator cuff, like the rotator cuff spectrum disorder or not. And one of these tests that are best for this is the pain arc. And if you try to abduct the shoulder and there's no pain here, no pain down here, but pain from 60 to 120 degrees, then that's a positive test. And all the green is from this study, the JAMA study. They usually have these JAMA. They have this JAMA series called "Does my patient have X?" This is, does the patient with shoulder pain have rotator cuff disease? And it's like a comprehensive review of the tests that are existing. And again, these tests, there's a YouTube video going through these tests really smoothly and fast if you want to look it up. But the main take home for these tests are they're low evidence. They're all the studies are done in an outpatient clinic setting, so they don't necessarily extrapolate to our population or our setting in the emergency department. Okay. But if this is positive, then it can distinguish between rotator cuff spectrum disease and other reasons for shoulder pain. All right. Then you have the drop arm test, and if the patient with the drop arm test is positive, then increases the likelihood of any kind of rotator cuff tear. So you lift the patient to this height, and then see if they can hold their arm. And this is the weakness test. And then there's this is also one of these like general tests. If this is positive, and this is this is the external rotating test, where you rotate against the examiner pressing, and if that produces pain or weakness, then it's a positive test as well. And then that will just, so let's say if you do these 3 tests that we just showed, and they're positive, then okay, you might have, for not necessarily for traumatic disease, because this is an outpatient clinic, right? Patient population. So it's mainly these tests are mainly for degenerative disease. Okay, but they might extrapolate to pain in traumatic patients, but it's just, we don't know. Okay, then we'll go into these. These were like the general tests. Then we'll go into more the special tests where you try to test for special muscles or syndromes. So again, all of these studies that are done in not our patient population, and they look for pain and weakness, but some tests are better for pain and some are better for weakness. Okay, so here are the weakness tests for rotator cuff tears, right? And we already went through these, so I don't want to go through these again. But these were the ones that I went through with this slide. Here's the empty can test, where you try to make the patient fully stretch out their arms, and then fully pronate their arm as if they're holding a can, and then trying to pour it down into the ground, and then they will push down, and you'll try to pull the arms up. No, sorry, the opposite way around. They'll try to pull their arms up, and you'll try to push down. Let's see if it produces pain. Okay, and then you have your weakness tests. Then you have your pain tests. These are like what you call provocation tests, and these are usually for impingement, bursitis, calcifications, and so on. All right, and the classic ones called the Nearest test and the Hawkins test. You can look them up by yourself. In this study, they have little value, so I've not put them in. But it's usually like these are the ones that you're taught in school usually. But the positive pain arch is probably better if you want to know whether or not they have impingement or not. In general, in these studies, so each of these weakness tests can have, they have an active version where you push against the doctor's hand, and they have a more passive version. And the passive versions, if as we talked about, what you would call the lag test, where you try to put the patient's arm in the position and then try to see if they can hold the position. They seemed to be better in general than the classical test where you try to push against the doctor's arm, especially to rule in full cuff tears. Yeah. So that's what was one of the take-home points in this YouTube video about this study here. So that might be this test, like the lift-off test behind the back, where you let the people, where you try to, like the active test would be letting the patient press against your hand with this movement, and the passive lag test would be telling the patient to hold their arm here as long as they can, and if they cannot, then the arm will move in and the test will be positive. Another of these tests would be the doing the external rotation. The one test would be like the active test would be to push against the doctor's arm when you're trying to externally rotate, but the passive test, the lag test, would be to hold the patient's arm here and see if they can hold it there. And the last one would be the drop test. And this is the active test here would be the full can or the empty can test, depending on if you pronate or not pronate the arms. And the passive test would be abducting and then seeing if they can hold their arm out there. Okay. The entire thing, all of these, this is from the study again. And here you can see the full write-up of all the tests. I just wanted to show you how bad the research area is actually. Here are the tests that we talked about, like the painful arch. It has a likelihood ratio of 4 if it's positive, and negative of 0.4. So that's all right. It's only from one study though. So yeah, and here's the Hawkins test. The Hawkins test is a good negative predictive value, and especially if it's combined with the Nearest test. These were these pain provocation tests, but the Nearest test in isolation is not good at all. Then you have these strength tests, and they are quite good, um, especially the lag version. These are the lag versions of them. As you can see, there's one lift-off test, the active lift-off test. It's not as good as the equivalent um, lag test, right? So here you can see like the lag tests are better than the active tests. Also here you see the empty can test, which is often said to be should be used, but it's not that good a test in this. And this actually 3 studies saying this. Yeah, so this is the here you can see why it's difficult with this. Okay, so this is a summary slide of the test that you might consider doing for the rotator cuff tears and the impingement syndromes, right? Okay, that was that. That's out of our system. I hope you've learned something about rotator cuff. Please check the links that I posted in the beginning. I think this might help you to diagnose a bit more shoulder pains in the and diagnose them correct in the emergency department if they show up at your emergency department. They do in Sweden, but not necessarily in Denmark, where it's more filtered population. But what I guess one of the take homes was all of these special tests. I mean, the traumatic tears, I would look for pseudoparalysis. That's the most important sign, right? But if they have weakness after a trauma, especially anterior shoulder dislocation, then you should consider whether it's neurovascular or it might be a shoulder injury, a cuff tear. And if it's a cuff tear, then you should ask orthopedics to follow them up quite quickly to see if they should be operated on, right? That's kind of the take home. All right. Then you have AC separation, and the short of the matter is, well, there are 3 types. There is the one that hurts, but they're in line in X-ray. There's one that is totally off. It's misaligned. There's no articulation left. This one is up here and the other one is down here. And the one where it's in the middle, there's a gap, but there's still articulation. Usually they fall on their shoulder. And usually they're sore in the AC joint. You do the X-ray to rule out clavicle fracture. and sometimes you need to do a bilateral to actually see whether there is a type 1 or type 2. But as a rule of thumb, they should not be operated on these. But I know there are some in the literature that where they should be operated on, and I think it was according to EM cases this, if the AC distance is increased by 100%, like it's totally off, it's 100% off, or more than 5 millimeters, then they should consider operation. But these are usually not operated on, as far as my experience is. Okay, other things we already talked about: impingement tests, the impingement syndrome at length, repeated luxation or the subluxations. We've already talked about these. Like that was the T and golf analogy, where you should maybe consider operation if the apprehension test is positive, but you shouldn't do the apprehension test just after a dislocation, because it might be false positive, right? Then you have your frozen shoulder, and these are more common for some reason because of diabetes. So in your diabetic, you should definitely make them move quicker after a fracture for lots of reasons, but among other for this reason. And then the treatment is mainly patience. It will get better with rehab and physio and cortisone injections, but it takes time. So that's important again to tell the patient. Arthrosis, usually part of the rotator cuff spectrum syndrome, right? If you have an X-ray where there's calcifications and you have hysteresis, and yeah, it's usually part of the impingement part of the syndrome, and usually it's the same non-operative treatment as impingement syndrome. And then you have your proximal biceps. We talked about that. It should not be usually not treated at all. All right, moving on to the last area, or joints. in this lecture, and this is the back. One of my, as a someone interested in neurology, one of my favorite areas. And even though these patients may be quite difficult for a lot of emergency physicians, myself including, because there's a lot to go through. They are usually in severe pain when they come. They're usually at the end of their rope, kind of desperate to get some kind of relief. And we'll go through systematically how to assess these patients and how I think we should assess these patients. And also we'll go through the mind-boggling hard task to not miss, especially cauda equina. Is when you think about the literature on this, it's really like if you have any suspicion, you should do an MRI. These MRIs are so difficult to convince our radiologists or our neurosurgeons usually to do. And at least everywhere I've worked, it's been a huge problem. This, and because there's so many patients where you might suspect the diagnosis, and the MR, there's only so many emergency MRIs that you can get in one day. And so you really have to be able to triage and examine these patients really well. And there might be a few tricks that you can utilize to get a better sensitivity and do as much as you can bedside as possible. This may be one of my favorite areas as well, because there's this huge it's a vast importance to inform the patients and to do compassionate care. And to explain to them in a way that they understand why it's not like most of them have to go home and it's not dangerous. And this is mostly achieved if you have a compassionate care kind of approach. And we'll go through that a little bit as well. Okay, so let's start. So the back, I'm going to go through the cervical spine as well, but mostly the lumbar spine and the thoracic lumbar spine. Yeah, and then the cervical spine at last. We'll go through it with the atraumatic and then the traumatic afterwards. The only pearl I have is like most of these patients, 90% of the patients that present with an atraumatic back pain, maybe after lifting, maybe not, are going to have some kind of biopsychosocial problem that needs to be attended to. The last 5 to 7% that have red flags, they need the the biological part mostly. Okay. Anatomy we'll go through, especially with the cervical spine. I think there's little anatomy that is relevant for the emergency physician down here. Maybe just the neurology we'll just go through quickly. So when assessing the non-traumatic back pain patient, of course, it's important. It's really important with the Socrates OPQRST mnemonic for pain management, like site, onset, character, radiation, alleviating alleviating factors, timing, and like surgery. And you can also do the OPQRST plus, depending on what kind of systematic you have. It's important to some aspects that are really important is whether or not it's traumatic, of course, whether or not there are neurological symptoms, especially weakness is one of the red flags that is on the border of being something that they can go home with or not. And it's almost always warrants a consultation if they have severe weakness. So that's one of the pearls, right? But if they only have sciatica or radiculopathy, like unilateral radiculopathy, and it's usually not something that needs to be attended to with admission or MRIs, but something that has to be followed up. You also have to do your maples, especially for IV drug use and cancer history, along as well as weight loss. Right. There's several things that could be included here as well. You might do rheumatological or autoimmune disease as well, and so on. The exam, I think, is really important when someone presents with back pain, or the chart says back pain, that you're thinking really widely. Some of these patients may present with flank pain. Some of these patients may present with back pain or thoracic pain. It really depends. So that initial step where you need to consider, okay, what is this, is something that um, you need to think really widely to begin with, and you may not be able to totally hone in on which area of interest it is before you actually examine the patient and get the history. And sometimes you have to work up several areas at a time. One of the examples is someone having back pain on the thorax level, thoracic level, and maybe a bit off the midline. So what is that? That could be thoracic pain. That might be a lumbar, like that could be a pulmonary embolism and the pulmonary infarct. It could be if it's quite low, it could be anything intra-abdominally, such as pyelonephritis, or it might be, if it's more central, it might be back pain, and then thoracic back pain is very serious because it might be cancer, or it's a red flag to have thoracic back pain. So yeah, so there's a huge differential suddenly with these things. And if the pain cannot be reproduced, then you might think of vascular injury, such as ruptured aortic aneurysm, especially if it's lower back pain. So there's a lot of differentials here, and I think it's really an interesting group to work with because your exam findings are so important. And there are a few but really important things that you need to do right. Okay. So you will check the vital signs, and this is especially for the more serious stuff, like vascular injuries. But usually they should not have any vital sign defects, right? They should be stable otherwise, these patients. So if they have vital sign deficits, then it's a red flag. Then you go on to the neurovasculature, and here it's good to remember, as we talked about, the dermatomes and the myotomes. And the dermatomes, here you have the rule, or the kind of rule of thumb, where you say L3 is the medial knee, L4 is the kneecap, and L5 is the lateral knee, and then S1 is the little toe. Then you're testing for disc herniations as well, at least almost all disc herniations, I think it's like 98%, are in the lumbar part. And we'll include like the L4 to S1 region. Myotome wise, it's L3 is the patella and L5 is Achilles. And so L5 will also be making the patient stand on their heels. S1 would be making the patient stand on their toes. Yeah. So and flexion of the knee, like a straight leg raise would be the L3 as well. So and always look these up. Don't trust me sometimes, and different sites might say it a bit differently, but it's important to test all of these things, and then you have made a kind of a map of what the problem could be. Then you do the inspection. Sometimes some of these conditions might have obvious deficits, but mostly you won't find anything by inspection. You might see that the patient doesn't want to lie down. With radiculopathy, usually it's better when you're standing, and with disc herniations, usually that's better when you're lying down, especially with a flexed back and flexion in the hips, so they're like in a prone, in a foster position, or fetal position, right? And they might be deviating to one side. They want to, classically, mechanically, you would say that they're trying to open up their back so that they're leaning away from their radiculopathy, so that the so that the area is not compressed. Okay, this is very important to palpate. So we talked about referred pain with these intra-abdominal things like vascular injuries, ruptured aneurysms. And I must say I've had a few of these patients actually where they present with maybe like nuances in vital signs. It's not necessarily that they're hypotensive and really in a bad way. The pain might also have been would be gone by the time you see them as well. That makes it quite difficult. But in general, palpation wise, if you cannot, it's the same as the rest of the body. If you cannot reproduce their pain, and I mean reproduce, I don't mean it's just a bit tender here. And when you palpate their back, it has to be reproduced, right? Because if it cannot be mostly reproduced by you pressing, then you should think that it might be some referred pain. Though the disc herniations usually they might have spasms in their muscles, but you cannot palpate the discs in the same way. You cannot palpate the area in the same way. They might be somewhat tender, but usually it's more like a movement thing. But it's like if they have pain with movement like that, then it's kind of the same thing as a palpation. But if you have someone who has pain that is like you cannot really get at it at all, and you don't have any other signs that might suggest that it's something more benign, and especially if they're older, then you would think ruptured aneurysm, especially if they have vital signs that are problematic. There might be other stuff than the normal, like the classical ruptured aneurysm. There might be ectopic pregnancies with bleeding that might radiate somewhat to the back sometimes. It might be a retroperitoneal bleed as well, such as spontaneous bleedings in these areas. These are rare, or with falls they might happen, but it's something that also to think about. And and if you're using a POCUS for ruling out intra-abdominal bleeding and ruptured aortic aneurysm, it's important to know that the retroperitoneal bleeding cannot be ruled out with a POCUS. So it's not a definitive test if you think of retroperitoneal bleeding. Okay. Another reason why it's important to palpate the patient is that for the infections, for the epidural abscess and so on, they will often, not always, but often be tender on a specific point, on a specific process, spinosis or vertebrae. Yeah, and also with the fractures. The fractures might be a bit more difficult, especially if you have an osteoporotic older patient, because a lot of them are chronically hurting, and there's no other side to compare this with, so it's hard to say what is their baseline. But if they jump really high, I always find it really hard to actually assess these things, and often I end up doing a CT scan if they had a trauma and they are hurting a lot. So so this is a difficult population. So palpation is important, right? And movement is important as well. There are certain you want a back aching patient to actually be able to move before they can leave the emergency department. Of course, they don't have to be able to move a lot, but they have to be able to do their own ADL. They have to be able to provide for themselves, and if they cannot do that, then I guess you sometimes have to do the dirty deed, as it's seen as, and actually admit them. All right, so there's a couple of special tests as well. We talked about like muscle tests, like walking on tiptoes would be the S1, and walking on your heels would be the L5. But you might also do the LASEK test. The LASEK test is quite sensitive. I think it's like 80%. We'll have it in the next couple of slides. And it's if the thing you're looking at the thing you're looking for with the LASEK test is at 30 to 70 degrees of straight leg test, passive straight leg testing, a straight leg raising. they will reproduce this radiculopathy pain all the way through down their leg. And you might, once they have had this kind of pain, you might lower the leg just a little bit, and then you could dorsiflex their foot. And that's the I think it's called Backward maneuver, which might increase the sensitivity even more. And according to ortho bullets, having a positive LASEK is a sign that they might be good candidates for potentially surgery. Then it's another question whether or not they should have that, but they might be some of the patients that might benefit from that. Okay, you have the crossed LASEK as well. That's raising the other leg and getting pain in the first leg. It's specific, but it's quite insensitive. I've only seen it once or twice in my career. All right, so let's move on. That's kind of the comprehensive examination. But what you actually need is having all of these, like when you're taking the history and doing your exam, you have to have these red flags in your back of the mind and as a checklist, and we'll go through these now. All right, so lower back first here. Before we go through the red flags, I promise you just a bit of anatomy. I think the relevant anatomy here is that you have the medulla going down to L1. Above L1, there's no medulla. Okay, so sorry, above L1 there's medulla, and below L1 there's only these threads that we would call the cauda equina. This last part here is what you call the conus medullaris, and and it's important because if the conus medullaris is still a part of the medulla, and if that is if you have a compression, as you might have known from my neuro lecture or from your own studies, if you have a conus medullaris or a upper motor or you have a medullary compression, then you'll get an upper motor neuron syndrome, which will with time progress to hyperreflexia, maybe in days to weeks, and weakness of a spastic character. So if you try to raise their leg, they will have a spastic kind of jerking movement, as opposed to if you have a lower motor neuron, then they will usually have hyporeflexia or areflexia, because it's only the roots, it's the lower motor neuron, and they will also have weakness, which is flaccid as opposed to spastic, and they might also get atrophia with like severe, like a prolonged time. So the thing is that these things usually only occur after a couple of days to weeks, so they don't occur acutely, like hyperacutely. They take a little while to develop. At least these ones. These ones don't. These may be what you see right away, but you cannot really distinguish between these two. If you get an acute lesion, the upper motor neuron lesions would usually look like the lower motor neuron lesions as well. So everything looks like a lower motor neuron lesion to begin with. You can think of strokes. They will not have Babinski positive before a couple of days, hours to days after. And the same goes with these central lesions. Okay. So these are the don't miss diagnoses, and the figures of how common these are varies, but it's around 5 to 10% in according to like my core references for this is Jonathan Edlow's back aching, emergency back ache article from 2015. It's the core pendium from EMRAP on back pain, and it's the neurosurgery back compendium, along with a few other scattered sources like UpToDate. But these are usually the ones that are mentioned. So you have vascular, don't miss diagnoses, especially ruptured aortic aneurysms and ectopic pregnancies, but also dissections and retro peritoneal bleeds, which most of the are like the ruptured aortic aneurysms would be. You also have dissections. Of course, dissections in the belly are quite rare, but dissections in the thorax are quite common. So that's also a thing you might consider. There are plenty of other things that might like in the abdomen that might radiculate to the back or radiate to the back, but usually they have belly pain as well. Just like pancreatitis is told to go to the back usually, to radiate to the back. But usually you'll have other findings that suggest that the problem is situated elsewhere. But that might not be the case with these things. They might be occults. Okay. Then you have infections, and you have your epidural abscesses, you have your discitis, and your osteomyelitis. These are usually seen with drug addicts. I've seen a couple, and all of them have been using IV drugs, despite one, I think, and that was an immunocompromised patient with HIV. So immunocompromise or drug addiction are usually some like high risk factors for these. Then you have your cancers, and the cancer that usually spreads to the back are prostate, lung, and breast cancer. All the cancers potentially can seed to the bones, I think, but they do it in decreasing the like more and more uncommon. These are the common ones, right? And what we always think of here is also medullary compression from cancer. That's like a big we don't miss. Then you have fractures, and fractures, of course, if you have a high risk trauma, then you'll think of fractures and they come in on a spine board or similar. Now that we've kicked out a lot of the spine boards, but the more occult ones are the patients with osteoporosis, right? Or the patients that we don't know have osteoporosis, the frail patients that fall and have back pain, right? So the old elderly patients, we need to think of these, and some of them are so osteoporotic that they will have spontaneous fractures, right? And they need to be attended to as well. We also need to think of if some of these like special cases fall and break or fall on their backs, like morbus Bechterew or rheumatic diseases, right? Then we have cauda equina and conus medullaris. These are also don't misses, and we'll talk about how we might not miss these, but this is really difficult. And then we have rheumatic problems, such as ankylosing spinal disorders, right? So these would usually be your patients with rheumatic diseases, like morbus Bechterew, but may not be diagnosed yet, right? So it might be the presenting feature that we need to find. It might not be a true don't miss as the others, but I'm usually it's something that it's nice to pick that up if you find it. So from this list, we can make this list of red flags especially for cord compression and cauda equina that we should pick up. In literature, there is this tuna fish from the history that tuna fish mnemonic that the history findings that are red flags, such as trauma, unexplained weight loss, that's for cancer, or also rheuma problems, neurosymptoms. Of course, especially motor symptoms, not unilateral radiculopathy, unless it's something that occurs along with other red flags, such as cancer. If you have radiculopathy, back pain, and cancer risk, like you recovered from breast cancer 20 years ago, then it's definitely something that you should work up or consider working up. But as a rule of thumb, though, unilateral radiculopathy, like pain radiating from the back going down below the knee, is not something that you usually have to work up in isolation. Then, of course, IV drug use and age above 5 and fever, age above 50 and fever, immunocompromised and steroids, and also syncope. Syncope is one of those things that you might think it's a vascular thing. They might syncopize from just like extreme pain, but then it's highly unusual for someone to syncopize from back pain, right? So you need to work up what could this be. And then I guess if they're dystonic and they have like this theoretical back pain, then you have to think of pulmonary embolisms as well, and so on. So syncope is something that warrants a bit more of consideration, right? Then you have your history of cancer, as we talked about as well, as long as weight loss. And what goes along with this is the exam findings that are red flags. So if they're tender on bone, that gives a suspicion for infection or fracture. Or if they're really tender on muscles and they're like really bulky and or may have fallen, then you should, I guess, consider compartment syndrome as well here. If it's pain out of proportion and so on. If the pain is not reproduced, I would consider one of the intra-abdominal things as well. If the patient has IV drug use, of course, I guess the exam here would be if they have track marks, or if they have other signs of drug use, or if they are high right now, then these things might be indications. Fever, along with other vital signs like hypotension, are of course exam findings that are red flags. Then you have CES, cardiac equina syndrome symptoms, which would be the triad of, especially the triad of muscle weakness in the legs, either unilateral for cardiac equina or bilateral for conus medullaris, or other medullary causes. Then it would be saddle anesthesia, which can be asymmetric, and then it's urinary retention, which can exist or cannot exist, depends on whether, as we will talk about, whether this is an incomplete or a complete cardiac equina syndrome. The incomplete cardiac equina syndromes are so hard to pick up, and that's the reason why we have to probably do more MRIs that we are doing for these patients. But if they have a complete cardiac equina syndrome, then usually they will have urinary retention, and actually so much so that if they don't have a post-void bladder volume of more than 200 cc's or 200 milliliters, then according to one study, it has a negative predictive value of 99.9%. The study is cited in the compendium of EMRAP. And then reduced anal tone is also a red flag, right? And we'll talk about how specific, how bad the inter-rater reliability for this actually is, and we probably should go away from doing this if we're following the literature. Then you have severe motor deficits and progressive motor deficits. So these are red flags, and sometimes your consultant will say, it's all right. They can have no Achilles tendon reflex, and that's all right. But I would suggest that you consult someone if they do have motor findings, especially if they have weakness and not just Achilles or reflex problems. But it depends on local guidelines. But in general, motor findings is a red flag, which they might be sent home with, but only after consultation. Progressive, like a week ago, I was weak in my weak in one place, and now it's progressed. That's a really red flag, and they should not be sent home with that usually. All right, and then there's the better with movement, and it's more like the semi-red flag of rheumatological disease or inflammation. Yeah. All right. Of course, also if it's involving multiple joints, or they have inflammatory markers such as anemia on blood samples and so on, that might also be cancerous, suggesting of cancer, right? So, okay. Most people, though, around 90%, depending on which study you should look at, will be what you call undifferentiated back pain, and we'll talk about how, which like if you can go into a bit more specifics about these. But in general, these are managed somewhat like the same way. What they need is information, that nothing is broken. They don't hurt their back if they cannot break their back by moving, but they should move with their as their pain allows. And then we should not try to get them in, like we talked about, the spiral of avoidance, or the avoidance behavior that we, in the beginning of this entire lecture, that we should try to avoid with our patients by communicating that this is a benign condition and they should move as much as they can. All right. Then it's important to do the pain and expectation management. So most of these patients, if you take this entire group of undifferentiated patients, most of these will be pain-free, or at least almost pain-free, or at least be better, depending on the studies, within 6 to 8 weeks. Sometimes it's set 3 to 4 weeks, right? So there is light at the end of the tunnel, but they have to go through pain for a couple of days, especially if it's like an acute event, like a herniated disc. But then it'll be better really within a couple of weeks, and it'll be gone within 6 to 8 weeks, something like that. The ones that don't go, the ones that don't become better usually have biopsychosocial problems, or they might be operative cases. So psychology and operation after the 6 to 8 weeks is the rule of thumb, or at least the discussion of it. The reason the treatment of the pain is usually NSAIDs and paracetamol. The evidence for NSAIDs versus paracetamol is bad. There's no studies saying that this one, or there's no consistency in the studies saying that one is better than the other. Sometimes you might use opioids, especially if they come into the emergency department and you have to break like this vicious cycle that they might have come into, with back spasms and no rest and anxiety, and like even everything is tense. So I think it's not a bad thing to actually. It's reasonable to be a bit more aggressive when they present in the emergency department, and maybe use opioids and maybe more at that point. But that doesn't mean that they should go home with that. It's just to it's the same thing with migraine patients or other pain crises that might come into your emergency department, because it's not the same as if they're at home. It's something that has escalated or accumulated. It's a component. There's a there are components, both the biological, the and the psychosocial. They're afraid and they're anxious. They're about that, whether this is something really really painful, like really bad happening to them, if they don't know about it from friends who have had it maybe. That feeds into their catastrophizing and so on, as we talked about. So we have to break this kind of spiral and this tensing of their body, and I think like you can do a bit more in the emergency department under surveillance, and then you can send them home, oftentimes with just NSAIDs or paracetamol, and then with opioids and good information and compassionate care, right? Opioids as well if they need it, and only a smaller dose, right? After careful consideration. When do they need to come back? Well, if they can't get out of bed because of pain in just a few days, then they definitely should come back. You might tell them something about how to get up from the bed. Like they shouldn't use their back. They should get their legs out of bed, and then they should laterally raise their body, so that they don't use their back. And then try to move. Don't exercise necessarily, but try to move each day. Don't just stay in bed. And if they have any of the red flags that we're talking about down here, especially progressive motor symptoms or bladder symptoms or saddle anesthesia, then they should come back right away. Okay. The reason why I'm so thorough about this the green population here, the majority of the patients, and the information bit of this, is that from Bendixen's back compendium in Denmark, there's this graph here that I think is for someone who loves functional disease and or functional disorders and biopsychosocial things in emergency medicine, especially, then this is really important, right? So this is a graph showing that like the back problem as a whole thing through the ages, through the 1900s and 2000s. This is not an accurate graph. It's just a depiction of what we think has happened. The pain, like the entire back problem here in 2000s consists of mainly a small increase in the biological component, but mainly it's the behavior, the pain behavior, and how the patient behaves, how we as a system behaves towards patients with pain, and how we as doctors might not be able to follow up on patients. So they see different doctors who says different things to them. There's no consistency and so on and so forth. Like a complex problem leading to a huge back problem in society, which mainly is not biological. It's mainly psychosocial, right? All right, and here was again the visual cycle and cognitive behavioral therapy, which is so important here as well, right? Because if you go into catastrophizing, we have to break this circle. We have to break the circle for the patient. I'm not saying that we should do this in emergency medicine, in the emergency department all the time, but this is part of the back pain patient assessment or treatment. And we should at least plant a seed and try to confront this with the patient. And we do this by being thorough, by being compassionate in our interaction with the patient, and how to be compassionate and how to do compassionate care. I've made an entire video about this before, so I don't want to go into details with that, but just saying here it's important. Specifically for the lower back pain patients, there's this great video by Dr. Mike Evans, a Canadian GP, I think, doing videos for the Canadian system, and they tell all of the good facts that you might want to tell patients. Also, again, neurosymptoms.org is a good place to start with these kind of symptoms. All right, then moving on, just saying that other people have made really good algorithms, and this is from Edlow 2015 on low back pains in the emergency department. Where he also, all of these have some kind of high risk, low risk, and the intermediate risk that kind of need blood samples usually, and it's usually if they have more than one red flag. They have posted their red flags down here. You can pause right now, and then you can read this or read the paper. But in general, just to be thorough here, there's something also called there's green in the literature. There's something called red flags, as we talked about, usually for risk of severe disease, and then you have something called yellow flags, not to be confused with this, because yellow flags are, as I remember, these are yellow flags are risks of the patient becoming a chronic pain patient. This might be something like earlier chronic pains and a high anxiety towards the diagnosis or towards the condition, or bodily distress, or it might be having a work-related issue keeping them from or if there's money involved, and back pain is part of this complex of not being able to work. If you have back pain, and then you can get compensated for it. Not saying that they're malingering, but it's a yellow flag and the risk of chronicity. Yeah, and then you have the low risk flags usually, which would be called green flags as well. Okay, I've made a blog about pain patients as well, so you can check that out on our blog for Danish readers. Okay, so who needs imaging then? Well, patients without red flags on exam and pain has not been more than 3 to 4 weeks. They don't need any imaging. And even if they do need imaging, right, it's not necessarily said that they should need imaging in the emergency department. They might as well do it at their at their GP, right? So it is, especially as many of these, the imaging that we need is usually an MRI, and we all know that we cannot get an emergency MRI, especially not for someone without red flags, right? So expectation management when they come through the door is important here, and I think it's important again to emphasize we need to see where the patient is, try to manage their expectations with a compassionate care approach still, and then try to do what Ken Milne would say, NNC equals 1. Just make them a little better. See to it that your interaction with them makes them just a little better. Just plant a seed. You don't have to fix the entire problem, but you can get them to the next step in this, and get a new get information or get a new understanding of what is happening. Because I think that's really important. We cannot fix a lot of these problems, but we can at least be compassionate and try to help and do actionable things that might get them to the next step. All right, you need MRI for CES, for cauda equina, for the infection, and for cancer as well. But cancer is something that you can work up at the GP, right? And again, monoradiculopathies without cancer risk don't need any imaging. Without any other red flags, right? Don't need any imaging. I'm not saying that also if you have infection, if you think that this might be an epidural abscess, it doesn't just because they have radiculopathy doesn't rule out that it can be an abscess, right? So I'm saying no red flags, but only monoradiculopathy. Well, then you don't have to do imaging usually, unless you really need to in terms of operation, whether or not they should go to surgery and so on. But that's a subacute thing that the GP should take care of, not us. All right. It's important to emphasize that CTs and X-rays are mainly for bony anatomy and maybe the vascular emergencies as well, or definitely the vascular emergencies as well, but not for disc herniations, not for infections, it's not really good for malignancy, as we'll see as well over here. So if you have any compression symptoms of neurocompression, then it's MRI. If they cannot do an MRI, there are certain patients, I've maybe done this once or twice, if there are certain patients that cannot do an MRI, maybe they were so anxious that they cannot fit into the MRI and stay there to get good imaging. Maybe they have some kind of implant and your hospital cannot manage that. Maybe they have some old bullets in their body and so on and so forth. Then they can do a optimal test called a CT myelogram, and I'm not sure of the sensitivity and so on, but if in the situation, if that's the best you got, then you have to do what you can, right? All right, so just going through just a few bullet points for each of these vascular, or each of these red flags, right? I forgot to bring on this epidural hematoma on the other one. Epidural hematomas are usually from some kind of trauma, and the patient is usually on some kind of anticoagulants. So usually there's that I've never seen one of these, but they do exist as well. And it's, I guess, the main reason why you don't want to do an LP on anyone with blood thinners on board, even though it's mainly theoretical, as I understand it, the risk. Okay, so vascular things, just like ectopic pregnancies, ruptured aortic aneurysms. If you have an age above 50, of course, for the ruptured aneurysms, not the pregnancy. And if you cannot reduce the pain and they might have vital signs that are bad, then you could do a POCUS. A lot of these, if you're good at POCUS, then you might find bleeding, or you might free fluid in the abdomen, or you might find an erupted aneurysm, or at least an aneurysm that is an aorta, more specific, an aorta more than 3 centimeters big, right? But usually you'll need CT scans because small amounts of blood below 500 milliliters can be missed on a EFAST, right? And depending on the patient, usually what goes first is about the vitals or a positive EFAST. I mean, so if you have a suspicion, then you should do a pregnancy test and a CT. If you really have the suspicion. All right, infection. The thing about infection is that sedimentation rate and CRPs are in some studies quite sensitive if they don't have any CRP and ESR and they're not distinctly tender on any bone, then it's probably ruled out. The sensitivity of percussion tenderness on specific bone is 86, so it's quite a good test. I mean, not in isolation, but in as a tool, it's a quite good test. They don't have to have fever. I think fever is only present in maybe two-thirds of these, maybe less. And they don't have to, of course, to have drug use, but that's a common reason why. X-rays in certain X-rays may be good sometimes, but they're not quite as sensitive as MRI. And the important thing with MRI is that you need an MRI of the entire spine when you do it. So I mean, sometimes I've been told by the radiologist to do a CT first, but usually MRI, and then treat the patients with antibiotics and then admit for MRI. So sometimes these are utilized, but they cannot rule it out if you have a high suspicion, high pretest probability. So and it's important to do an MRI of the entire spine when you do it, not just the location where they're hurting, because they might have skip lesions and so on. Okay, cancer. So we talked about prostate cancer and breast cancer and so on, and lung cancer are the other ones that are most commonly metastasizing to the back. And it's important to know that, like with breast cancer, it can happen 20 years after they're cured, quote unquote. It's also important to know that patients may not have cancer history. They might just present with back pain as they're finding. That I think it's like maybe 10%, maybe more, that actually do present with their cancer diagnosis like that. Thoracic spine pain is a red flag for cancer. Almost no one have thoracic spine pain, in my experience, and the ones that have had it, I've at least have had one or two patients that came in with this and had cancer. So this is something that's out there. So if they have thoracic pain without a decent like traumatic history of or something like that, then it's something to be really it needs to be worked up. Not necessarily if they don't have any neurological symptoms in your emergency department, but through their GP needs to be worked up. And one of my cases, I remember, had a negative X-ray done by the GP. So it's important to emphasize that the X-ray is only 60% sensitive for lytic and blastic lesions, which are the ones that we're looking for. I think it's something like the late lesions they only become visible when they're quite late. I think it's something like 50% of the bone needs to be lytic before it actually can be seen on an X-ray or CT, something like that. I'm no radiologist specialist at all, but just to say that if you have a high suspicion, especially with a thoracic spine problem, it's not enough to do the X-ray. You should have some kind of MRI if you have a somewhat high suspicion. Okay. There's this from the Corpendium. They said that weight loss plus cancer history plus age above 50 plus therapy failure, like normal backache therapy failure, has 100% sensitivity. So the combination of these definitely. All right. So fractures, especially the occult fractures, maybe even non-traumatic fractures or mildly traumatic fractures in elderly, frail patients. You'll do CT scans more than X-rays because X-rays are good, but they might miss some, and the CT scans, I think, in most hospitals I've worked are now the standard for these cases. If they don't have any neuro symptoms, of course. If they have neuro symptoms, then it's another thing. Then CT scans and then maybe an MRI to depending on what kind of neuro symptoms, of course. If the CC does have a fracture, then you will do pain management and see, especially mobilizing pain management is really important that you get up and walk, as we talked about during the hip fracture part of these lectures, and to see whether it's stable or unstable, of course, and then osteoporosis workup if it's unknown to them that they might have osteoporosis, because this is an osteoporotic fracture. All right. The CES is the triad of, just like any neurological problem in the medulla or just below the medulla, the chorda equina. There's a triad usually of paraparesis or paresis at least in one leg, and bladder symptoms or anal symptoms, and a sensory level, which at the CES would be the saddle anesthesia. And there's also this thing with residual urine that we'll talk about. But if they have no residual urine, then it's at least not a complete lesion, but it might be an incomplete still. All right, and then you have the rheuma patients, and there are this 4 out of 5 of these criteria. Then if they have 4 out of 5, then you'll have a 95% sensitivity for this. So for ankylosing spondylitis. So age below 40, pain not relieved when lying. And improved with exercise, which is like this classical rheumatological inflammatory pain. Morning stiffness as well as classical, and then pain duration above 5 months. Okay, so let's go through chorda equina just quickly here, and EM cases have done a great one on this. I think it's episode maybe 29 or something like that. It's a quite a long one, but they also have the best case ever, and they have a quick hits on this as well. So please check that out. There are, in general, 3 presentations, right? And in general, sometimes the terminology is mixed up here. So you have chorda equina syndrome, which was the below the medullary level. So they will present with lower motor neuron syndromes. It will usually be asymmetrical, as opposed to the conus medullaris, which is medullary. They will present with upper motor neuron syndromes, and they will be, or upper motor neuron syndromes if they have gone on far enough or for a long enough time. But usually, but if they present really acutely, then they will also present with acute, almost lower motor neuron syndrome-like symptoms, right? But they will be bilateral, as opposed to the chorda equina syndrome. Then you have the incomplete, and that's when it's really problematic. And you want to catch the incomplete ones, because once they become complete, then they have a bad prognosis, right? Yeah. So it's for the clinicians and for the patients. This is a really, really tricky thing, and it's hard to see sometimes how you should do this without scanning a lot of patients, and the system is just not geared for scanning a lot of patients with MRI right now. So that's it's a catch-22 for us. Okay, but there are 3 presentations usually with chorda equina syndrome. There's the acutely one with acute prolapsed disc, herniated disc, like sudden back pain and then motor deficits and cannot they have bladder problems and so on. That's the more obvious one. Then you have the end stage chronic back, like an acute on chronic. That's a more subtle one where you have chronic back pain and then subtly they progress with this. And then you have the slowly progressive saddle anesthesia and urinary symptoms. These are the 3 presentations. And as we talked about, they can be complete or incomplete. And it's important to know that incomplete ones do not have these quite sensitive urinary problems, right? Not necessarily, at least. The chorda equina syndrome is almost half of them are from herniated discs, but they can present from a lot of other problems, like infections, all of the other red flags like malignancy, but infections or bleeding and so on. They're anything compressing the area. As we talked about, it's lower motor neuron syndromes and asymmetrical, and the conus medullaris, because it's T12 to L2, it's upper motor neuron, and it's usually symmetrical. All right, the classical talking about the chordae equina here, the classical symptoms is usually back pain. Not necessarily though, as we see here, they don't need to have back pain. They can present with only urinary symptoms, and as I recall, there is a case that Patrick Croskery, again from his archives of cognitive biases, his cognitive autopsy book, he usually talks about this case where urinary retention. I mean, usually we don't think about urinary retention as a back problem or surgical problem or any problem other than a urological problem. But if you have a patient with urinary retention, you should always do an examination of their legs and do it like a back neurological examination, because they can present with this alone, and the saddle anesthesia might not be that obvious if you don't ask the patient. Okay. So that's really that's one of the pearls with this chordae equina syndrome. If you have urinary retention, always check for the back neurological symptoms. Rule out chordae equina. Okay, but a lot of them will have back pains, and these might be chronic, of course, but and some of them might be acute and chronic. Then you check the dermatomes. The dermatomes for S2 to S4 is the saddle anesthesia around and you can ask the patient whether or not they feel loss of genital sensation. This may be unspecific or unspecific because a lot of psychosomatic disorders might present with this as well. But they might have changed sensation as well. They might have anal numbness, which the British would say numb bum. Like when they're wiping or when they're sitting on the toilet, they cannot feel when they're sitting. That's questions that you might ask. 75%, according to studies, will present with this. So it's a somewhat sensitive sign, but not totally sensitive. And it can be asymmetric. It doesn't have to be bilateral, as we talked about. And then the risk of if you have bilateral sciatica. So remember we said that if it's unilateral sciatica radiculopathy, then it's nothing to be that worried about unless there's other red flags. But if it's bilateral, then it's really that's like a classical presentation for conus medullaris, and also chordae equina sometimes. Okay. Then you have your myotomes, and this is the tricky part because a lot of the herniated discs can come in with mild motor symptoms, and this is where it really gets tricky. And this is why you should always consult someone, at least to get your back, like have a clear back, because I mean, if it's areflexia and it's quite sudden, then it's something to be worried about, right? Or something to consulting at least, especially if you want to be 100% sensitive catching these incomplete CESs. And I don't really have a solution to this, but if they have severe motor symptoms or they have progressive motor symptoms, then I would probably press my consultant for doing an MRI. And if they have mild symptoms, and maybe not, especially if they don't have urinary retention. But again, this is really difficult. Then you have your ANS symptoms, and your ANS symptoms are the anal sphincter disturbances or rectal tone. And this is partly ANS. This is also a myotome, but it's important to, like, this is what they say in EM Quick Hits from these studies, that a rectal tone has a wide inter-rater variability and poor accuracy for the diagnosis of chordae equina syndrome, and is unlikely to alter pretest probability in the diagnosis. So you shouldn't rule anything out. If they don't have if they don't have a missing rectal tone, and a lot of patients probably it's really hard to what is the baseline tone for these patients. If you have a young fit male, then of course, well, they should be able to press your finger and squeeze your finger really hard. But if you have an older patient, in my opinion, it's usually quite hard to distinguish what is normal rectal tone for this patient and what is like barely, and then you will end up doing a lot of MRIs or weighing this symptom too much. So I usually don't pay too much attention on the rectal tone unless it's someone who I know would have a good baseline tone. Okay. Then you have urinary function disturbances, and these are becoming more and more important in the literature. So some literature would say any alteration in the sensation of a full bladder does a desire to pass urine or awareness of passing urine. So it's it's not just the first couple of symptoms are not that they necessarily cannot pass urine always. It's sometimes also that they cannot feel that they're passing urine, or they don't have the desire to pass urine. Like they don't feel the urge to pass urine. So these are important things to pick up, um, because these might be the first common symptoms that you need to be aware of. And then when you treat the patient with pain management, and sometimes that's the difficult part. Sometimes the urinary retention can be pain related. If they present with acute back pain, then they're all spasmed up and tight. Then you can try to quickly try to give them pain relief if you can, and then see if they do a post-void bladder scan. And if the post-void bladder scan is below 100 to 200 milliliters, again, depends on their baseline. Again, if you have a young patient, then they should not have any urine in their bladder. But if you have a older patient with LUTs, that is really, or prostate problems, right? That is really a problem of where is their baseline. So you might check that up in their charts, but then this sign becomes less efficient. And as far as I'm concerned, like urinary retention is 90% sensitive for CES, right? But it doesn't find the incomplete ones necessarily. Yeah, but it's important. Like this is probably a more important test than the rectal tone. Do a post-void bladder scan for these patients. The later symptoms is that they cannot feel their bladder, they don't feel the urge, and they cannot void, and then they'll become overflow incontinent, and that's the late symptoms, right? Other things that you might ask the patient: can you stop the urine midstream? And there's different these questions in some of these articles that might come in handy for you. But again, so if you have the suspicion, and I'm not saying when you should have the suspicion, I'll probably if you have any of these presentations, you cannot find any other reason for it, and you might have. Of course, if you have saddle anesthesia, that's one thing. That's definitely a red flag, and always yields MRIs. But if you have just the myotomes, these are the ones that are difficult, or the ones that you have urinary retention with back pain but nothing else, especially in someone who had LUTs, then it's really hard, right? And then it's a discussion point with your consultants. But MRIs is what is needed, and we should have a low threshold to order them, because it's actually the only one thing that could rule out the salvageable incomplete CES. All right. And the CES. All right. And then there's a matter of how fast it needs to be done, and the literature is disagreeing on this. Our course managers said that usually it's within 24 hours, but well, if you have symptoms, you should not wait. It's more like if we don't really know, then they might observe them a bit, but as early as possible if necessary. Okay. Then let's look at these, the 90% people that usually that don't have any red flags. What are the differentials for them? Well, it might be a muscle sprain in one of the big muscles that can hurt like hell, and and usually you will be able to palpate their muscles and see that they're hurting. Then these usually get better before these weeks of pain. Disc herniation we'll talk about. This is one of the most common, right? Then you have degeneration and pseudo-claudication, like stenosis, and we'll talk about this here. But degeneration, in general, backache from degeneration, osteoporosis, and so on, is age-related, right? Then you have your sciatica, which usually is understood as the radiculopathy, monoradiculopathy being the major part of the pain, and the backache maybe being the lesser part. I remember our rheumatologist in Denmark used to say that, like, the usual progression of pain is so that the first 2 weeks are the pain from the gelatinous mass in the middle of the disc breaking through the annulus, and just, like, making some kind of inflammation in the area. That's why NSAIDs and paracetamol works in this kind of time. But when you move on beyond the 2 weeks, then it's more of a radiculopathy pain usually, according to them. So this is anecdotally, but according to them. So and at this point you might have just sciatica, right, without any back pain left. And we talked about how to treat this with if they need to try to treat it with neuro pain meds, right? So like gabapentinoids or and so on, and how how these are quite risky medications usually, and so it's a shared decision making and not something that we should start in the emergency department with the patient. There's the piriformis syndrome as well, which can create sciatica. It's like it's also called, I think, called dancer's hip as well. If you externally rotate the patient's hip, it'll induce the pain, and it's better in when they move. And you have stenosis. Stenosis is usually they can be stenosing in different places. It's classically better when they're leaning forward, standing like a gorilla, and it's worse when they're getting up or standing straight up. And usually this needs, I mean, the operation versus no operation is controversial. Let's just put it at that. It's not our decision to do anything. Then you have your spondylolisthesis, which is an anterior slip of the vertebrae, something that a lot of young people have. Especially if they hyperextend their bodies, like in gymnastics and so on. And I'm not quite sure what the significance is of this. In the American literature, I think they usually say that this should be followed up somehow, but in Scandinavia, I'm not quite sure what the significance is of this, and what the prognosis is of this in terms of, is there any risk of disease from this, or is it just a radiological finding that we should just ignore? A few times I've seen this, I've not done anything about it with the patient. I've told them that they have it, so they didn't know it, but not anything else. And you have spondylosis, which is age-related dysgeneration, just to like, and it's important to say, like, during the MRIs, you always have to correlate their symptoms, even though their literature is quite pessimistic on that, then you should try to correlate their symptoms with your findings, as always, because a lot of us walk around with asymptomatic disc herniations, just as we talked about in the shoulder with the rotator cuff tears. Okay. Let's talk about the back pain without red flags. As we said, never admit them. That's usually the mantra in the emergency department, but sometimes it's really hard, so good luck with that. Anyone who's worked in the emergency department with backache patients know that there is definitely some that are really hard. And I think a lot of it goes a long way to just think of these patients as having a pain crisis. You need to acutely fix that with an aggressive management and compassionate care, and then oftentimes you can release that kind of, like, they're happy to go home afterwards, a lot of them, right? So do the cocktail, do the compassionate care, and then the ones that are left, sometimes they have to be admitted. So let's talk about the disc herniation. So according to the sources on the Compendium for EMRAP, there is like 98% of them are L4, L5, or L5, S1. Right, so it's really rare to have a disc herniation anywhere else. Usual history is disc pain, or you have the disc pain, as we talked about from our Danish rheumatologist. Sudden pain after lifting, usually, which improves with lying with your knees and hips flexed. And that might be and might not be with radiculopathy. Our rheumatologists would say that it usually develops over weeks, but it might be acutely as well, I guess. And this usually improves with standing. It's worse when you're sitting and using the Valsalva, and it might be LASEK positive. And it's usually it's below the knee, just as radiculopathy below the elbow or distal to the elbow. There you should think about radiculopathy and not pain in the shoulder, right? Okay, so if they have sciatica radiculopathy, that would be 95% sensitive and 88% specific for disc herniations. Remember, disc herniation is actually a clinical diagnosis and the MRI is not needed for most of these, as we talked about beyond, if they as long as they just improve within 6 to 8 weeks, or at least improve somewhat within 3 to 4 weeks. And according to OrthoBullets, if you can reproduce the radiculopathy with the LASEK test, then according to OrthoBullets, then it's quite a good predictor of potential candidate for surgery. And we'll talk about what the benefits of surgery might be and what the risks are. And the LASEK test is usually sensitive to 80% and specific to 40%. I'm not quite sure what the golden standard is here, because the MRI findings, as we talked about, are so complicated to actually assess. So I'm not quite sure how good a golden standard that is tested against. But yeah. And then of course they might or might not have motor deficits, and I'm saying, just as a rule of thumb, motor deficits should always be either followed up or consulted with your consultants. And I usually will consult motor deficits, especially weakness, right? And if it's progressive weakness, then always. Other things, you might see them leaning to one side, the other side of the radiculopathy, and then they might have limited range of motion. They might be spasm in their muscles as well. And what you do is decent pain management. It's good compassionate care and thorough exam is really important. Expectation management that we talked about. And move as much as possible, though not exercising in the acute phase. This is for herniated discs. I guess for muscle sprains and ligaments, other ligamentum problems and so on, or strains and sprains. I would suggest that, and this is anecdotal and from very low evidence, but I would suggest that they actually keep working out to actually to avoid this avoidance spiral. Keep working out, but just lower weights, a lot lower weights, maybe 30% of what they usually lift, and then if it feels alright, then they can progress from there instead of just lying perfectly still. This is the literature on sports medicine about these things are not something that I've delved into and take it with a grain of salt. So my source for this is the Starting Strength program and Barbells Medicine, made by 2 doctors as well. So it's low evidence, but at least some. And from my own experience, I can tell you that as well. All right. Doing the pharmacological cocktail is controversial, right? So according to EM cases, there's no benefit of choosing NSAIDs instead of acetaminophen. It's the same thing, though when they present to the emergency department, at least our one, they usually have already tried either one or both. So it's important to catch them where they are and say okay, you should do this, and you have to do it regularly, and you have to and we'll give you, maybe you need to maybe utilize the placebo effect to kind of get them out of that kind of knot of pain and spasm, right? So use the other one that they have not used. That's usually what I do. But of course, if they're NSAIDs have much higher risk profile than acetaminophen, so keep that in mind. Then I would usually also add morphine. Some of my colleagues would add morphine IM because they think it works for a longer time. I'm not so sure, as long as you're just dosing it right. The PO should be at least 3 times the dose of the IV, right? And there's some who would say that because of pain, the gastro system is not working as well. So all pain meds should be given either IV or IM. I think I could buy that, or at least because of the placebo effect, there might be some benefit as long as you're just weighing up the risk of putting an IV in them and thrombosis and so on. So I would say usually I would give them IV or give them IM, and then say like to lean in on the placebo effect and say like we really have to take care of you now, and we'll try to fix this. It'll and then expect their expectation management, so but try to catch them where they are and then just try to get rid of their pains as good as possible, right? All right, and then some people would also add muscle relaxants. This might be benzodiazepines, like not sending them home with benzodiazepines, but in the emergency department, just like again to release this kind of an. I'm not giving migraine patients benzodiazepines home either, but I'm using it for the London treatment usually. That I kind of the same thing as also with a placebo element here, or to like so that's or healing response or. Right. So it's really I really think this is important with these patients. And then you might use other muscle relaxants as well. The evidence is really sparse on this, and on other pain meds like gabapentoids and so on are not non-existent evidence as well. So, and there's no evidence to suggest that one NSAID is better than the other. Usage depends on the profile. According to Motov on pain-free ED, he would usually say that there is a ceiling effect for NSAIDs, so that everything above 400 milligrams of ibuprofen that doesn't help and will only increase like risks. So 400 milligrams of NSAID or of ibuprofen 3 times a day, right? You might give naproxen or any of the others that might be a longer release. But there is no like benefit or harm between these. Ketorolac is sometimes what we use because it's often used and it can be given IV. So yeah, the patients who can go home are the ones that, of course, don't have any red flags, and they must be able to ambulate and take care of themselves when they come home, right? So this thing about not admitting them, usually you'll give them this, examine them thoroughly, and then see how they're doing in an hour or two. And if they cannot stand or not walk, or they don't really want to, or then sometimes you have to admit them. But oftentimes they will go home. Right? It's really a challenge though if they have acute on chronic pain. And a lot of biopsychosocial risk factors and yellow flags and so on. That's a problem. And we talk about when do we need more to do MRI or to do something like that. Then, of course, red flags, or if they're not improving. But that's usually for the GP to, like, we can send a letter to the GP saying that. And it might be good to know, according to orthopedics, the risk of operation is usually you can have a dural tear, which may or may not be a big problem. You can have recurrence, and that's over 8 years, it's like 5 to 15% will have recurrence in the same area. You can have wound infection, and you have discitis as well. These are the main risks for the operation. So the benefits that you might get, if you have red flags, then there's high benefit, and you should do it usually. But if there's no red flags, then it's usually quicker healing if the patient population is selected well. Remember what we could talk about, nociplastic pain. If you have the acute on chronic pain patient, then this might not, there might not be any injury left in the area, but the pain is a behavioral thing that they have learned, just like post-cholecystectomy syndrome, or all the other kind of nociplastic syndromes where the trauma, the noci stimulus is gone, but the pain is still there, and it's because it's still in the brain, right? So always think of psychology before you think of operation. Okay. I just wanted to show you the LASEK here. LASEK here, passive leg raise to 30 to 70 degrees, not more, because then it will hurt them usually in their hamstrings, and that's not the pain we're looking for. And then you will feel radiculation, And the radiculation, if they feel radiculation here, and then you'll just lower the leg just a little bit, and then you'll try to dorsiflex their leg. That's the bracket, the more modified leg. There's other modifications as well, and one of them is like if you flex the knee, then the pain might relieve as well. I usually use these two. Okay. And here again was another biopsychosocial. Have I mentioned I like biopsychosocial models and the psychological part of the pain? Yeah. All right. Moving on to the traumatic back. So in general, with traumatic backs is like a third of these will be cervical, and 15% of the cervical ones will have neurodeficits. So just because you have a cervical fracture doesn't mean that you have a neurodeficit, right? The most common ones are the C2, C6, and C7. And the C1 and C2 are a bit different, and the C3 and until C7 are the same, right? So C1 and C2 are a bit different, so we'll talk a little bit about those. We should be aware that if you have dish or Bechterews with a fracture, then there are certain very important considerations to take care of. Their fracture is being kept up by their muscle tone, right? So if you sedate them, then they might die, and then they might just totally decompensate their back. So always lie them in a position that they feel comfortable with. Don't lie them flat on the spine board if they don't want to and they don't feel comfortable with it. And be careful with sedation with these patients without knowing what you're doing. Lie them on their. It's always safe to lie them on their side, or like what we were told is you can always do that. And they can have unstable fractures with low energy traumas, and they usually need MRIs, right? And then it's important to know that if they have neurosurgery and neurosymptoms, then usually there's actually no evidence, from what we know, for decompressive surgery. There's a lot of opinions, and I have no idea about this specific literature, but that's what we were told for the course. So even though they have, it's important to notice, but we can't really do much about it. There are a few neurosymptoms that we need to know about when you have the back, like the back patients with, like traumatic back patients with neurosymptoms. You have something called SCIRORA. SCIRORA is, I cannot remember the acronym, but it's in essence, it's there's been a medullary shock, right? Without any, like the medullary part, like the nervous system has been injured without any fractures happening. Can happen especially, I think, with children where the bones are weak, but the bones are soft. But you can have this injury anyway of the nervous system. Then you have something called autonomous dysreflexia, which is usually something that only occurs a few days to weeks after the injury, but it's something to know about as an emergency physician. And I've seen it a couple of times when I worked in neurology. It's this syndrome where below the lesion you will have if you have any problem or any like there's a dysregulation. The normal autonomic nervous system cannot regulate in the same way that it usually does. So if there's a noxious stimuli below the lesion, then it might create a hypotensive crisis above, where there and a lot of other symptoms. So it's a crisis where you need to remove the clothes of the patient and put in a catheter, pain relief, and maybe remove obstipation and so on and so forth. Then you have spinal shock. Spinal shock is kind of like if you want a detailed description of this, you should check the YouTube channel Intranest and the series orthopedic series 1 to 4. But the spinal shock is if you have a like the nervous system is stunned, but it will recover. But you don't know whether the patient actually has lasting injuries or just is in spinal shock. that like the nervous system is recovering. On you don't know that on until like weeks later. There are certain ATLS and ECC teaches that there are certain prognostic symptoms or findings that you might find before you sedate the patient in the trauma bay, which might be like something like bulbous cavernosus reflex of the penis and anal reflexes. But you have to check that up for yourself. It's just to know that spinal shock is like a stunning, like the nervous system is stunned, and it's reversible. It'll come back, but they're weak, and it seems like they have lost spinal, like the spinal, the medulla is injured irreversibly, but it isn't. Then you have neurogenic shock, and again the terminology here, but neurogenic shock is the classical shock where the nervous system, the ANS, cannot press on the vessels, so you need vasopressors to actually fix that. And it's the one occasion in trauma where you usually will use vasopressors as opposed to blot. Right. And you have to think of the C3 to 5 keeps the diaphragm alive. Any lesion above the C3 will make them will hurt the phrenic nerve, right? Totally, and then they usually have breathing problems. And it's always it's important to know that when thinking of the cranial nerves and trying to assess at which level the patient has a problem, then the Horner syndrome is not a cranial nerve, that's the ANS. Okay. All right. So getting into first let's take the thoracolumbar fractures first. And here you can talk about, you have compression fractures. Compression fractures is like axial loading, where the vertebrae is decreased in height. You can have normal compression, and then you can have bursts where it's almost like comminuted, and it looks like this. All right. Then you have the distraction fractures, which is fractures across here, and then you have the translations fractures, which are obviously usually the most dangerous, because it's like a translation. It's dislocation of the entire spine, and you can see like the central canal here would be highly decompromised. Okay. So there are a system called the SLIC, the subaxial injury classification, and I mean we don't need to know this as emergency physicians. If they have a fracture, we'll just talk to our consultants usually, because it's a bit complicated. But if the main thing is, do they have any neurodeficits? That's really important. And then we should think of what kind of fracture is it, and depending on what kind of fracture, it'll give them more points, right? And the more points, the more risks, the more likely it is that they need surgery. It's important to like the most fractures that we will see in emergency medicine is usually the compression fractures, unless you work in the high trauma centers. And it's usually these like compression or burst fractures from osteoporotic elderly ladies or males, right? And it's important to see that compression fractures can maximally give you 2 points, no matter the complexity. Okay, so they can look really bad, but they need 0 to 3 points for surgery, as a rule of thumb, according to this system. So if you have a compression or a burst fracture, then on a lumbar thoracal level, then they don't need surgery as a rule of thumb, right? Unless, of course, they have neurological symptoms or they have some kind of disruption in other areas of the C-spine or the spine. And of course, if they have polytrauma or they have dish vector Fs, then there are other factors that you need to consider. Okay. So this is the classification system, and you can like, is it displaced or dislocated or translated? Then, well, no. Okay. Is there a tension band injury, anterior or posterior? Then you can begin to nurture your way into that. But if they don't have any tension band and they don't have any displaced, and it's only a vertebral fracture, then usually they might not need any and might not need that much. Okay. So this is a slide I borrowed from the course. I think it's like the A injuries, like the compression injuries. It's only involving one of these. We'll talk about. There are 3 columns, and it's only and if more than one column is involved, then it's a problem. And because of the burst fractures are only involving one column, then they are, as a rule of thumb, stable. The bead injuries, like and the ones that are across here, they involve both the front and the back the columns, and often you need MRIs to actually to assess these, and usually you need to contact or always contact someone with these. And then the C injuries are obviously something that needs to be they always unstable, so they always need to be considered for operation. And then it's quite good to know what the definition of unstable fractures actually are. And the definition is that they don't tolerate force applied to them, because then they will shift. So it's a clinical diagnosis with a but also radiologically informed, right? So an unstable is if when they mobilize they have pain or they get worse neurological deficits, all right? So if a patient is walking into your clinic and they fell from a height, as one of my patients at a location in Denmark once did, I think it was a German patient who had fallen from a kite surfing accident and walked into our clinic 4 or 5 days later, and he was sitting and we were like, oh, this X-ray is terrible. He had a really bad back injury radiologically, but he like movement didn't increase his pain, and he didn't know neuro deficits. So then it was kind of considered stable, even though radiologically it might have been considered unstable. So this is all about pretest probability again, right? And it's all about context and all about clinical assessment. So an unstable fracture can only be assessed if you know how the patient is doing, right? Not only on radiology. And there's this like if it is stable, then it's stable, right? It's been proven stable by walking. And of course you need to, if it's been stable for weeks, then it's probably stable for weeks to come. But sometimes you need to follow up that with several x-rays, right? And then there's this study, usually one of the treatments for these like stable fractures is corsets. But there's this Bailey RCT from 2014 that the course directors made us aware of, that says that it's no better than like verbal movement restrictions to give a corset to patients, and they hate corsets. So it's definitely something that's to think about whether they need it. I've had a few elderly patients that really become almost suicidal with their restrictive garments, just as like corsets. It's really something to think about. Okay, cervical spine. So all of us know that there are these decision rules or tools that we are using. Some might be using the Nexus rule, some might be using the Canadian C-spine rule. I like I have a bias. I like the Nexus rule because the creator is Jerome Hoffman, one of the emergency physicians that I really look up to. And he's made it as a clinical tool, and it's made in a way you can read his comments on MD Calc about it, and if you look up Nexus rules and then scroll down to the author's comment, but it's mostly like you need to use your brain. It's not like a rule where you think, oh, this patient doesn't need an X-ray. Why do I have to use this rule? It's a rule that is more sensible and more pragmatic. Some studies would say that it's a bit less sensitive than the Canadian C-spine rule. And again, if you want to like do a deep dive, then check out this video. It's the EMU. I think it's Rohit Mohindra. Talking about like going through the evidence and going through C-spine rules. And like, go check this out if you really want a deep dive on this. The problem with the Canadian C-spine rule is that it says all patients with head trauma always needs a CT, right? And that's a lot of head trauma CTs for these patients, C-spine CTs for these patients. And in truth, the study was not done on above 65-year-olds, as is said in this video. So you cannot say that it's can be used, and you cannot say that it cannot be used. So that's different than having the evidence for that it cannot be used. That is an important rule of thumb. That saying that there's no evidence it can mean that we have not studied it, and or it can mean that we have studied it and it's a bad thing. We shouldn't do it. So in this case, it's something that we haven't studied in according to this rule. So use your clinical experience. A lot of these older patients will need a CT of their neck, especially if you're getting a CT of the head. You should probably just consider doing a CT of the neck. This is an EMK's rule, and I've heard it several times before. It's something like 20% of the patients with a severe head injury will also have a cervical injury. So yeah. But check this out. I'm not going through these rules anymore. So check these out if you want to. Okay, so then the basics. I've borrowed this from Andy Neal. Please check out his video on cervical spine anatomy. So you have your this is the C2 to C3 down to C7 vertebrae. So just a bit of anatomy here. You have your vertebral body, vertebral body. This is this. Then you have your lamina. This is this. And you have your pedicles. This is this. And you have a spinous process down here. Let's see here. Yeah, and here. Okay. Looking at the C-spine or the cervical spine, it's really important to think about these lines here. There's the anterior vertebral line here. And then you have the posterior vertebral line, so you have the entire vertebral body here. Then you have this line called this spinal laminar line. And then you have like from the ending with the laminar and where the processus spinous begins. And then you have this posterior spinous line. And this one, as you can see, should have a bit higher angulation, and this angulation should end around the back of the head. Right? These should be continuous, these three lines, and we talk about there's three columns making up like the space between these lines. So you have the first anterior column, the middle column, and the third column. And if more than, as a rule of thumb, if more than one column is broken, then it might be a radiologically unstable fracture. So it depends on your findings as well. But yeah. Okay, and this is just to show that what kind of anatomy there is, because a lot of these are the ligaments, right? And the ligaments are quite important here, because a lot of this, especially when it comes to C2 and C1, the ligaments are really important. But also here the anterior ligaments and the so this is the red, the anterior ligaments, the posterior ligaments, the ligaments flavum, and so on, right? Okay. All right. So here again, another X-ray. Moving beyond the columns, you need to check the bones as well. And here's the dents. And here's the what you call the AGI, which is important. And you have this pre-vertebral soft tissue as well, right? And this is allowed to be below less than 7 millimeters up here, but then moving down, it's allowed to be bigger than that, up to 22 millimeters. And you can check the invertebral discs as well, and we'll go through this more in a systematic way soon here. And check the laminae and so on. Okay, so let's just move through this algorithm again, as we talked about earlier. So here, okay, So, look at something obvious. Is there anything obvious? And then accuracy and adequacy are all 7 vertebrae in picture. There's C1 to C7. We cannot see TH1, so that's actually not a adequate picture here. Is there alignment? Meaning that is there any it's important like this definition, a break on a fracture is a break until proven otherwise, and children might be difficult with this because they have variations that we cannot see, and might need different imaging as well. All right, so we check the lines, the spinolaminar line, and at C2. There might be a bit of posterior displacement that is all right, which we can see here. So if you check this line, this is why the angle is a bit bigger here, because the C2 usually goes out a bit more. That's all right. And then you look at the posterior line here, this one, and then it should curve behind the neck as we see. But you check the lines for the alignment. And they have to be smooth, right? They have to be smooth and unbroken. And you look at the bones, and I guess you look like the C1 and C2 are different. So you'll try to look at this. This I think always is quite hard to actually see in a real X-ray when it's not marked. But you try to see the dents. Then you try to see the C1 as well. See that it's and there's some details here that I will not go into. Please check out Andy Neal's and Rohit Mahindra's videos about this. And then you go through the surfaces of the other C3 to C4, right? C3 to C7, and you can check the height of them. They should not be compressed more than 2 millimeters. Then it's a compression fracture. And then you look for the cartilage, see if they're a uniform height, which they are here, and the joints, the facet joints here, and whether or not they are articulating. And they might be dislocated, and if they're dislocated, that's a big problem, right? And then you have this C1 dense gap, which you're looking for, and it should not be more than 3 millimeters. And if it's more than 3 millimeters, then you consider that there's a break, like in the rupture of the transverse ligaments. And then you check this shadow, the anterior shadow, and we talked about how much the anterior shadow is allowed to be. Okay. So that's roughly what you're going to do. You need to, as you can hear, I am not an expert in this either. So, but this is the way that it's taught in the ETC, in the European Trauma Course, and probably a good way to practice it systematically. Okay. So the kinds of fractures that you might see, let's see, like the C3 to C7, they're like the rest of the back that we just went through, the burst fractures and the transverse fractures and the translation fractures. But then you have your C1 and C2 fractures, and they're a bit different. So you can have the C1 and so you have the C1 and the C2, and the C2 has this odontoid process called a dens, and it's held in place with a lot of ligaments, among other this transverse ligament, which is really important. So you can have a different fractures here, and you can have occipital condyle fracture. These are uncommon, which is like the on the occiput, on the skull, where you can have a fracture around there. You can have a Jefferson fracture, which is a burst fracture on the ring, and it's often associated with other fractures as well. And the treatment depends on whether or not the ligaments are intact. So you need an MRI to assess that. And you have hangman's fractures. These are usually from hyperextension and distraction injuries. And these depends on the kind of type of fracture. Then you have dense fractures. These are quite common in the elderly, and the treatment depends on what kind of fracture it is. Usually it's conservative treatment with neck collar. Then you have facet joint dislocations that we talked about. If it's a true luxation, then it's really an operation, like an operation and an emergency. And if it's unilateral and it's different, usually conservative.